सर्वदा। ॐ गं गणपतये नमः। ॐ गं गणपतये नमः। ॐ गं गणपतये नमः। ॐ गणपतये नमो नमः। श्री सिद्धिविनायक नमो नमः। अष्टविनायक नमो नमः। गणपति बाप्पा मोरया।
गं गणपतये नमो नमः। श्री सिद्धिविनायक नमो नमः।
ॐ गं गणपतये नमो नमः। श्री सिद्धिविनायक नमो नमः। अष्टविनायक नमो नमः। मङ्गलमूर्ति मोरया।
ॐ गं गणपतये नमो नमः। श्री
Heli.
सिद्धिविनायक
Heli.
नमो नमः।
Heli.
अष्टविनायक
Heli.
नमो नमः। मङ्गलमूर्ति मोरया।
ॐ गं गणपतये
Heli.
नमो नमः। श्री
Heli.
सिद्धिविनायक नमो
Heli.
नमः।
Heli. request all the organizing committee members to take their respective daily positions. So we'll be starting within few minutes. Thank you. Hello. So can you just settle down and we are just going to start? Sorry, we are delaying the program by just by a few minutes, 3-4 minutes, but we are well in time, I think. So I am Rajesh Sharma. I am the Chief Administrator of NHS Hospital. I am the Master of Ceremonies for today's event. And I extend a warm welcome to all the participants, distinguished guests, the faculty members who have come all the way from right from Bangalore to Jammu to Ludhiana to Delhi, lot many places. So it's very national ambience. And we are rather extend whole of the NHS family, extend a very warm welcome to this event. At NHS, which is a multi-specialty tertiary care hospital, we are known for the state-of-art facilities for the patients with state-of-art technologies also to back it up. NHS is committed to the academic excellence also. Whether we have conducted already 2 master classes on headache and stroke, and these are the testimony to our academic excellence pursuits. And whether we started with the stroke and then we moved on to headache, and after a pause of 2 years because of pandemic, we are back again with epilepsy master class this event. This year event is very special in the sense that for the first time we have a registered body of neurosciences experts of Punjab. With the sincere efforts of our former President, Dr. Ashok Uppal, Vice President Dr. Gagandeep Singh, and Secretary Dr. Sunil Uppal, Punjab Neurosciences Society of Punjab is formed. And we have the proud privilege of holding the first inaugural event of this Neurosciences Society of Punjab as Epilepsy Masterclass. And we wish to thank IME Jalandhar also for collaborating with us to make this event a grand success. My humble request to all the speakers and the chairpersons that since we have a very tight schedule ahead of us for learning in this program, kindly stick to the timelines, and for facilitating that we'll be having a reminder bell at 19 minutes and a long bell at the end of 20 minutes. This is just to have for you all gathering here to have for the best of your deliberations and interaction with the audience. So here we come with the first lecture of the day. It's going to be a novel lecture from none other than Dr. Gagandeep Singh. So first of all, may I request Bindini and Kavajit to escort the chairpersons for this program. First lecture. May I request Dr. Vijay Mahajan, Dr. S.H. Chawla, Dr. Ashok Uppal, and Dr. Gabbar to be in the dais, please, sir. But sometimes when you reach in time, there is nobody to appreciate that you are reaching time. But here we are appreciating the person who reached in time, the first to come, and where the first percentage prize goes to Dr. Jaspreet Singh. His PNT number is 40776, and he is so we request him to just collect his punctuality prize and all the claps for him. May I request the chairpersons to introduce and call on the dais the first speaker of the event, Dr. Gagandeep Singh. Although he hardly needs an introduction, he is a big name in itself. So, sir, it's leaving from you.
I'm thankful to Dr. Goyal for arranging such a gathering on epilepsy and appreciating the effort to have gathered so many national faculty to deliver their deliberations. So with this, I will request Dr. Upal to introduce Dr. Gagandeep, who needs no introduction and well known to all of us, but still as a formality, I will request him to please introduce.
Good afternoon, everybody. First of all, I congratulate Dr. Goyal and all his team for organizing such a good show. And as it has been already told by the Master of Ceremony, that this conference is being held under the aegis of Neurosciences Society of Punjab. And this Neurosciences Society of Punjab is formed with the efforts of Dr. Gagandeep and other stalwarts from our Punjab state and other people. It will be a long list. I don't want to name because of the paucity of the time. So our endeavor is to connect all the neurologists and the other physicians and other like-minded people who want to know about neurology. Now in that sequence, now the first talk will be by Dr. Gagandeep Singh. And as everybody has said that he does not need any introduction, but still you know those people who are great, whose introduction is important because many people want to follow them. So Dr. Gagandeep, he is a great neurologist. He started the Department of Neurology at Dayanand Medical College, and now he is a professor and head of the Department of the Neurology. He did his DM from PGI Chandigarh. There are so many feathers in his cap, but the most important, the recent one is that he is also president of the Indian Academy of Neurology. I think his first love is for epilepsy. Of course, he is very much into all aspects of the neurology. You may name anything, toxicology, demyelination and everything. So I present Dr. Gagandeep Singh before you to highlight this very important talk on the epilepsy definition, recent classification, and he will highlight much more. So, thank you. Dr. Gagandeep Singh.
Thank you so much, my dearest friend, Dr. And please accept my congratulations on forming the Punjab Neurosciences Society. Am I audible? Yes? Right, okay. There is a little bit of disturbance, so I would like kindly bear with it. So please accept my congratulations for forming. All the hard work actually was done by Dr. Upal. I see so many friends here, but dear chairperson, Professor Mahajan would probably remember I first came to Jalandhar in 1994 and I had just passed out. Dr. Parampit, you would be happy to know that, and so many others here. And Dr. Mahajan had invited me for a talk. It was a small gathering, but it was such a vibrant gathering, and I think after that almost every few months I would come to Jalandhar, and I must say Jalandhar is really it has maintained that edge, two edges that it has really maintained over Ludhiana. One, it is much more clean, and I find it is much less polluted as compared to Ludhiana. And the other thing is this edge over and the enthusiasm for talks, academics, and so on and so forth. And I recognize so many friends here, so many familiar faces, and thank you for this opportunity to be with you. Dr. Goyal we have this long association, Sandeep. I don't remember how long, but it seems as long as the two of us have been here together. And he is such a great enthusiast. He trained in DMC and of course later on went to the GB Pant Institute and really that was a great turning point for him, and not only for him but for the entire community, the patient community as well as the doctor community in Jalandhar. So he is a great enthusiast. He is I think he is one of the finest neurologists, and I'm extremely grateful to you, Sandeep, for keeping this topic of epilepsy. And you've got so many good friends. I don't see Bhaskar, my friend, where he's there. Param is there. Dr. Guraya is there. So many of you are there. So extremely, it feels great to be here. Be relevant, pertinent, because if we have to keep pace with what is happening internationally, we should adopt the standards, the definitions, and the classifications. So I'm sure all of you would remember the traditional definition of epilepsy, which is 2 or more unprovoked seizures 24 hours apart. And there used to be this long discussion which I would have, and I would be party to it, and I'm sure you would have with your patients as well. When a person presents with a single seizure, whether to start him on anti-seizure medications or anti-epileptic drugs or not, and I'm sure you would tell the patient that many a times you may or may not have another seizure, so if you want to wait, it's perfectly all right. Actually start treatment, some patients who would not start treatment, right? It was like this, and I'm sure it is still like this. So the question is, when you have a patient with a single seizure, can you stratify, or can you discern or set apart people who are more likely to have subsequent seizures? So if they are at risk of subsequent seizures, they are at risk of lot many things, including injuries during seizures. Person is driving, he can have an accident, and there is something known as SUDEP. SUDEP is sudden unexpected death in epilepsy, right? So just like you have sudden cardiac death, that is a real thing. So by treating such a patient, you would not just prevent another seizure, you would prevent that person even potentially from dying or having a serious injury or serious morbidity. So of course, the traditional definition of epilepsy holds at least 2 unprovoked seizures occurring more than 24 hours apart. But even with a single seizure, you can make a diagnosis of epilepsy. And when is that? You need to understand that, because that has important implications in terms of prognosis. That has important implications in terms of starting treatment, right? So if you have an unprovoked seizure, and we'll come to what is an unprovoked seizure and what is a provoked seizure, right? But look at this graph. So a patient comes to you in the clinic, and he comes to you with a seizure, and there is a generalized tonic-clonic seizure, And I think you are obliged to tell him what is his risk of having another seizure in the near future. Let's say in the next 5 years, right? So what would that risk be? Any guess? You know, there are a number of studies, so there is a wide range. So anywhere between 20% and 50%, but an average figure would be somewhere around 30%, right? Okay, 30, or you might say 40%, right? So that's not great. That means the majority of people who have a single seizure might not have a second seizure, right? So which is what this graph, you know, the one which I'm pointing out, which is the dark line, is the risk of a second seizure after someone has a first unprovoked seizure. But if the same person has a second seizure, and you can see this in this particular graph, his risk of having a third seizure dramatically increases, something like over 60 to 70%, right? But if you think and you estimate that the patient has had one seizure, and you estimate that his risk of having a second seizure is as high as someone who has two seizures, which is more than 60%, then he certainly deserves treatment. Do you all agree with that? Right? So therefore, if after a single unprovoked seizure, you estimate that the risk of the second seizure is in the tune of 60 to 70%, then that patient probably has epilepsy and requires treatment. And when does that happen? That would happen if there is some kind of abnormality on clinical examination, neurological examination. Let's say the patient has a hemiparesis, or there is some kind of abnormality on the imaging. CT scan might show an infarct, might show some developmental malformation or whatever, or the EEG is abnormal, right? So that automatically elevates the risk of a second seizure, and therefore this patient probably deserves treatment. And the other thing that constitutes epilepsy even after a single seizure is a diagnosis of epilepsy syndrome. Very briefly, epilepsy syndromes are a characteristic constellation of clinical features. For instance, juvenile or an adolescent about 15 years of age keeps up the whole night partying. In the morning he has a seizure, which is a generalized tonic-clonic seizure. Also he has some kind of, you know, he's fidgety in early morning, he has some kind of myoclonic jerks. If he's holding a cup of tea in the morning, the tea spills off, he's brushing his teeth, the toothbrush just flies off. So those are myoclonic jerks early morning, and that is something known as juvenile myoclonic epilepsy, which is a very characteristic epilepsy syndrome. 10% of people with epilepsy have it. And if you are able to make that diagnosis, please start the patient on treatment. So that's the graph. But remember that all seizures are not epilepsy, and here is a list of conditions. Someone goes on an is a chronic alcoholic and is withdrawn from alcohol for a few days and then has seizures. Someone has a low sodium and has seizures. Someone has a seizure in relationship to drug ingestion, which is very common in Punjab. So, or has a seizure immediately after head injury or a stroke within 7 days. These are all acute symptomatic seizures. These are all seizures which are provoked by an acute neurological insult or a systemic insult, right? And therefore these are acute symptomatic seizures, and these do not amount to epilepsy, because the risk of recurrence over the long term in such people is extremely less as compared to, not extremely, is less as compared to that someone who has a seizure without any provocative factor, right? And this is the difference if someone has an unprovoked seizure and then someone has an acute symptomatic seizure, and this is the risk of recurrence, and you can see there is a huge difference between these two things, right? So this is about the definition of epilepsy. And the other thing is about classification of epilepsy, and this is also extremely important. Once you are sure that your patient has epilepsy and the key point here is that you can make a diagnosis of epilepsy after a single seizure. It's perfectly all right. But the next step is to classify seizures. And the idea behind classification is to be systematic. Some people do very well with this kind of these kind of wardrobes, but it looks nice. This certainly you will agree that this looks nice, and this is what we tell our children, right? So there are different types of classifications, but I will just give you a couple of examples. So this is an 8-year-old girl suffering from seizures since younger age. She has multiple seizures. She would pause in the midst of her work and would be fine within seconds, right? And the mother comes along with her complaints. Pehla ta top kardi si, she used to be a topper, but now she is not even in the first 10. So a decline in scholastic performance. Have a look at this.
जोर जोर से वो करके दिखा करके दिखा जोर जोर से
इसको इधर रख दो
ले मैं करके दिखा मार जोर जोर से मारियो ऐसे
100 टाइम
100 टाइम
What is the girl doing? Any idea? Hyperventilation. Excellent. Very good. You know it all. And see what hyperventilation is producing.
यहाँ तक उड़ा देना
So there is uprolling of eyeballs, few clonic movements of the eyelids, very brief, and she becomes absolutely fine there, right? So this is a classical absence seizure with a classical EEG of, and this is a type of a generalized seizure. So doing hyperventilation in the clinic, which you all can do, and if there are pediatricians here, that is something that you can probably do in the clinic. It can be done very safely without because absence seizures are really mild, right? I see Dr. Guraya there, and I hope I'm right, Dr. Guraya. Right, look at this. Right. So this is another girl. So there's something going wrong. She is pressing a button which is actually the seizure alarm button, which alerts the EEG technician, right? So medicine and neurology is all about observation, and even here we can get a wealth of information from just observing the child, this girl. She has a little bit of dystonic posturing of the left hand, which you recognized. She had some automatic movements of the right hand. She even wiped her nose, and these are all important clinical features which we need to observe. We have a sound here? Yes. Right. And she was actually responsive during the seizure. When the technician told her to lift her hand, she was able to lift her hand. She was talking during the seizure, which the voice was not playing. So this is also a seizure, and it is not a typical generalized tonic-clonic seizure, but this is what we used to earlier call as complex partial seizures. But ladies and gentlemen, we have to move with the time. The term complex partial seizure is no longer used. And we know that this is a focal seizure. It arises from the temporal lobe. It's important to recognize these kind of seizures, right? And we would call them, according to the current terminology, focal seizures with impaired awareness. Look at this one. Sound hoega? Okay. So this boy is sleeping, and he has about 30, 40, he used to have about 30, 40 such events each night. Only during the night time, not during the daytime. So the minute this whole thing was over, the sister asked, the nurse asked him what is his name, and he was able to tell the name, right? So very little post-ictal confusion, but very classical brief seizures, bicycling movements. These are frontal lobe seizures. And this is what the MRI showed. There was a cleft here, a developmental malformation. And this much portion of the brain was taken out, and the child is absolutely seizure-free after that. So this is the current classification. The first thing is try to classify seizures, whether they are focal or generalized, right? And I'll come to what are focal and what are generalized. And then try to look into the etiology. And this is a group of etiologies. It's common, any medical disorder you would classify etiologies like this, structural etiologies, where there is a brain tumor, a stroke or something of that sort, genetic, infectious etiologies, cysticercosis, bacterial meningitis, viral encephalitis, all of them can cause epilepsy. Metabolic causes, autoimmune disorders are extremely common these days. New entity which is being recognized. And finally, there is a huge group where we really don't understand what is the cause of the epilepsy, and then go into epilepsy syndromes. I think it's perfectly fine if you don't classify epilepsy syndromes, but do classify these seizures as focal or generalized, or you are not able to actually classify them, right? And the other thing is comorbidities. Remember comorbidities. Now, why I'm bringing up comorbidities is, and this is included in the current definition of epilepsy. So roughly about depression is extremely common in epilepsy. 30 to 40% people have depression. Anxiety is extremely common. Psychosis are common. There are a number of somatic and psychiatric conditions which go with the diagnosis of epilepsy, and please never ever ignore these comorbidities. This is extremely important when such a patient comes to you in clinic. So generalized seizures, ladies and gentlemen, is something that starts somewhere but eventually involves both the hemispheres, right? Right? That's generalized seizures. So basically, these are networks, and epilepsy is considered a network disease. And a focal seizure is which starts in one part of the brain. It might spread to the rest of the brain, to another portion of the brain. And therefore, it might be called as focal seizures with or without awareness impaired, depending on whether the person loses awareness or loses consciousness during the seizure. And therefore, please remember that the terms complex partial, although it was difficult for us also, and Dr. Parampreet will agree with me, we used to have a lot of problem adapting to this new classification, but these terms have just been given up, and we call them as focal seizures with or without impaired awareness, right? So what used to be earlier idiopathic is now genetic, symptomatic is structural, metabolic, and then cryptogenic or unknown. That's a huge number. So ladies and gentlemen, there is this new definition of epilepsy, and there is this new classification. It's really not confusing once you start using it, but I think it's important because it is now adopted by all international as well as national bodies. So this is something that we really need to talk about, which is we need to think in terms of the new definition. We need to think in terms of the new classification of epilepsy. So that's my request, and I'm sure you will be able to do it. Thank you so much.
Thank you, Dr. Gagandeep. As usual, masterfully talk today. So, any question, please? Most question.
Dr. Gagan, I just heard your lecture, and it was said that mid-fall epilepsy or abscesses are misformed. Now I have one ECG of today after the child is brought कि ये चाय पीते पीते ना 10 मार खा लेता है. He is physically abused, and he splits the tea. There's a motor component along with that. And earlier also the case, treatment given, he used to have maybe more than 500 thousands of attacks per day. Now, will this be called as petit mal still or abscesses or not? There is a motor component because he is always spilling tea.
I completely, Dr. Roda, with your vast experience, yes, and we are so used to using the terms, some of the older terms. It takes a long time for us to even at sometimes even now I would still use the term petit mal, but according to the International League Against Epilepsy, this term has been discarded, and we use absence seizures as. But I completely understand. So they say a rose would smell as sweet. What's in a name? I mean, it would just smell as sweet. But yes, then we have to keep moving with times, and which is what we are doing. Right.
Now, thanks, Gagan, for the excellent talk and videos. So same thing, so we use a lot of complex partial seizure when we discuss in our epilepsy surgery meetings and all. But the idea is that for trainees and who are going to appear for exams, that is important to know the new nomenclature. And for international collaboration, this has become easier because there were so many words being used. So that is the main idea behind ILE getting a standardized new classification. I just wanted to say that if you want to read more in detail about this classification and all, it's available free on the ILE sites, the papers of definition and the classification which Dr. Gagandeep shared. So you can download from there and read more in detail.
Thank you, Param. Thank you.
Thanks, sir, for a very excellent talk, and thanks to the audience.
Hello, good afternoon, sir. Sir, there are not only the classified ones, the unclassified ones, syndromes. So, how to classify those syndromes?
So there is a long list of syndromes, and you are absolutely right. Many a times we are unable to fit a particular individual into a syndrome, a given syndrome, right? So they have actually seen, and there have been studies in large hospital-based populations as well as population-based studies, where they have been able to classify people with epilepsy into a particular syndrome in about 30 to 40% cases, sometimes even less than that. So it's not that we can find a syndrome every time. And it's perfectly all right if you are not able to assign a particular syndrome for a given patient. Because it's important to know, I think so, whether we are dealing with focal seizures or generalized seizures. And sometimes focal seizures and generalized seizures can coexist in a given type of epilepsy. But that has important implications from the standpoint of treatment and investigations. You know, you are suspecting focal seizures. You would like to investigate the patient with imaging, right? If I know that this patient has genetic generalized epilepsy, I might actually avoid imaging, right? And then your drug treatment is also different. And I'm sure during the course of the day, we have some excellent lectures which will emphasize on how you can use this classification in deciding what kind of treatment to give. After all, the ultimate goal is to make the patient start the patient on treatment and make the patient seizure free. But the first step is being sure that this is epilepsy, using the current epilepsy definition and classifying epilepsy, so that you can then decide, as all the other eloquent speakers would tell us, on how to treat that particular case.
Another question, sir. There has always been a confusion.
Sir, thank you very much. I'm sure there are so many questions and which people would like to ask Dr. Gagan. Before I close the session, my co-chairperson has one query, sir.
I wanted to know when this all started with classifications. Because I was a student 68 in Delhi, and that was epilepsy and Gervadian, and we had no EEG machines. So when this EEG machine came.
Yeah, so 68 you are mentioning, so I think the first classification came by Henri Gusto in 1968. right? That was the first time the classification International League Against Epilepsy. And I think what you're saying is absolutely right. EEG is important, but I think clinical acumen and your clinical decision making is supreme, and EEG at many times does not really add to what your clinical decision is. So I think it's extremely important to clinically classify epilepsy, clinically diagnose epilepsy, and if you make a good clinical diagnosis, EEG helps, or just helps, or it supports the diagnosis. But eventually it should all be clinical. I completely agree with that.
Can we have a big round of applause for Dr. Gagandeep Singh? And Dr. Gagandeep Singh, please stay for a minute. Can we have the presentation and the memento from the chairperson to our honored speaker, Dr. Gagandeep Singh? तालियां तो बनती हैं, वो पंजाब वाला हाथ होना चाहिए. May I request Dr. Tarun Agarwal and Dr. Vineet Mahajan to honor the chairpersons also with plants. Thank you, sir. Thanks a lot for sparing your time, sir. Thanks a lot, sir. So here comes the second lecture of the today's epilepsy master class by Dr. Sonia Rai Chaudhary. May I request Bandana and Kawaljit to escort the chairpersons for this event or this session. Dr. Ashwini Malhotra, Dr. Ravi Paul, Dr. Manvinder Kaur Sapal, and Dr. Devi Arora. Kindly be on the dais, sir. Dr. Sonia Rai Chaudhary's topic is approach to first seizure in neonates, infant and child. Can we have the applause again for the chairpersons? May I request the chairpersons to call Dr. Sonia Rai Chaudhary on the dais and introduce her to the audience. The CV is in front of you. That's anything.
Hello, good evening everyone. So now we have a second lecture for the day. It is by Dr. Sonia Rai Chaudhary. She is DM in Pediatric Neurology from AIMS, and she has done her MD Pediatrics from SAFE GS Medical Center and Hospital, Mumbai. She has good number of publications to her credit. So I would request ma'am to kindly give us advice regarding the approach to a patient with a seizure in an infant, neonate or a child. How to deal with such kind of cases in daily practice.
A very good afternoon to all. So today, at the outset, I first would like to thank Dr. Sandeep Goyal sir for giving me the opportunity and the entire organizing team. So the topic given to me is approach to first seizure in neonate, infant and child. So seizures are a very common presentation in neurology practice. So both for the pediatric neurologist as well as the adult neurologist, which affects usually 8 to 10% of the population. However, for pediatric neurologist or a pediatrician, it is often the parents who visit us with the complaint that the child is having some kind of a paroxysmal event, and especially in the case of first seizure, a video may not be available, and the manifestations may be very different from those of the adults, and then the onus lies on us how to differentiate it from a non-epileptic event, and then diagnosing it, classifying it, and once we accurately diagnose a seizure and classify it properly, then that informs the choice of the cost-effective yet high-yield investigations. It also informs the right choice of treatment with, which will maximize the seizure control and minimize the comorbidities, and obviously will give a long-term prognosis. So as Dr. Gagandeep sir has already beautifully illustrated that the first seizure can be either an unprovoked seizure due to factors like it could be a head trauma, it could be triggered by a fever, or there can be unprovoked seizure, so where there is no obvious provoking factors, or it could be the first seizure of a new onset epilepsy, because sir has already said that when there is a first unprovoked seizure and still the risk of recurrence is more than 60%, so that time also with the first seizure we can still label it as an epilepsy, and our first seizure can also be the manifestation of an epilepsy syndrome. So when we are approaching first seizure, the few common questions which come to our mind is that, is it a true seizure? Is it the first seizure? Does the child have any specific provoking factors? So when we are dealing with children, we are obviously interested in the birth history, the neurodevelopmental status, whether it is triggered by fever, what is the seizure type and epilepsy classification, if any, the etiology, and accordingly, after doing a thorough history and an examination, thorough history review and examination, we focus on the investigations, we decide whether treatment is needed or not, and we obviously estimate the risk of recurrence. So first we need to differentiate whether the paroxysmal event with which the parents has complained and visited the OPD or to the casualty, whether it is a seizure or it is a non-epileptic event. So the main key to that is a meticulous history and a focused neuroexamination. So when we are eliciting the history of a seizure, few things we would like to know in details, particularly what was the preceding event of the seizure, like was the child awake, sleeping, playing, exercise, or did it follow some crying episode? Was there any provocating factors like a fever, as we see, because febrile seizures comprise a very common group in the pediatric population? Was there any history of head trauma, any preceding diarrheal illness? What was the child doing at the onset? The onset is very important because we classify seizure based on the onset. Then presence of aura. However, the younger child, like less than 5 years of age, they are not usually able to say the symptoms of the aura. So it is mainly for the school-going children. But however, in case of a small child like 3-4 years, sometimes we do get the history that the child is looking very confused, restless, comes and clings to the mother. So that also could be a sum of a aura before a focal seizure. And the ictal manifestation, similar to the adults, composed of a motor component. There could be some abnormal sensory symptoms in form of a paresthesia. There could be some confusion, some behavior abnormalities. And when we get the history of a tongue bite, incontinence, or some focal features, so we are more sure, okay, maybe we are dealing with a seizure only. And we are interested in the post-ictal observations, like how was the child post-ictally? Was he drowsy? Did he immediately return to the normal state? Or was there any transient weakness? And since the onset is in the childhood, so we would like to know, was there any antenatal risk factors? Was there any perinatal insult, like any hypoglycemic birth injury or a perinatal asphyxia? And since there has been a vast growth of epilepsy genetics in the last 20 years, and usually many of the cases present in such an early age group, so we are obviously interested in the family history of epilepsy and of course febrile seizures. So when we are doing, after a thorough history, we should go for the examination. And here we are interested in looking for some neurocutaneous markers like common in pediatric age group or the tuberous sclerosis, where there would be some hypopigmented patches, or it could be a Sturge-Weber syndrome, so there could be some capillary hemangiomas of the face. And always we look for some focal findings. And at the end, we always end with a developmental assessment. So in the next 2 to 3 slides, I would like to give a clinical, like how do children present to us and what is the usual semiology. So this is a 1.5 month old baby who has presented with these events from first week of life, around 5 days of life. The child was otherwise, the infant was otherwise non-encephalopathic. There was social smile and visual tracking response was there. So this child was actually gaining milestones. However, the child had this paroxysmal events. Coming to the semiology of the seizure, so we can see that there is some increased tone in the left upper extremity as well also in both the lower limbs, and there is also some facial twitching, and there is a eyelid fluttering also, but predominantly it is the left side. But if we see the seizure here, so there is a multifocal involvement mostly, but it is predominantly towards the left side, but there is also increased tone in the left lower extremity, and the right lower extremity is in the flex posture. So so this multifocal nature is a very common presentation in an infant. So this is a 7-month-old boy who has developmental delay microcephaly. He had a history of perinatal asphyxia, and now at 6 months of age, he has presented with these events of clusters, which particularly occur on awakening. So this is the classical video of a child with an infantile spasm. So this is basically a child with a West syndrome due to an acute cause. So this kind of semiology we don't see in the adults, but this is one of the most common causes of acquired epilepsy in the infantile age group, rather than an epileptic and a developmental encephalopathy. So in children, the red flags for the epileptic events in neonates, infants and childhood include some subtle seizures in neonates, because sometimes it happens that in neonates there may be subtle movements like some smacking, some lip smacking, some swallowing movements, or there can be some bicycling or bipedalic movements. So those can also be seizures, and it's very difficult to correctly diagnose without an EEG. There can be history of episodes of unresponsiveness or behavioral arrest, which can be associated with some autonomic symptoms or signs, and an event which occurs during sleep, and particularly this kind of cluster of events, particularly occurring in a child with a developmental delay, we would surely suspect infantile spasm. So these are basically the red flags, which differ considerably from the adult population. So now this is a 2.5 years old girl who has presented with this paroxysmal event since 10 months of age. So the first video is at 10 months of age and the second is at 2 years of age.
কিন্তু ডক্টর ले जाना पड़सी ये सब रो मत
So as we can all see in this video that in this video the child is having some staring look. She is not responsive to the parental commands, and she is having some lip smacking movements, some swallowing movements. So there are some orolingual movements, and eventually the child has a hypomotor episode, that is there is a loss of tone. So this kind of a seizure also happens in the neonates, which is basically a focal seizure.
पकड़ो पकड़ो
Yeah, baby.
So in this video, what we saw is that at the onset, the child had some tonic abduction of the arms, so which was more predominant in the left side. So as the child ages, like with age, the seizure semiology evolves, and the focal seizures are not that focal, like it becomes more complex, more elaborate, and more distinctive with the age. So in infants, so a temporal lobe semiology in adults would present like a ipsilateral hand automatisms, contralateral dystonic posture. However, in infants, it would be different in form of that. It could be a behavioral arrest episode with hypomotor episodes with some orolingual movements. And focal seizures sometimes in neonates may have a very generalized manifestation. So even there is a diffuse tonic posture, so there is some epileptic spasms. Although the seizure may look very generalized, the etiology could still be focal. And obviously, aura and bilateral synchronized discharges are more commonly seen in the older age group. So now coming to this video of a neonate. So this is a healthy neonate who are having these movements on day 3 of life. So as we can see that there are some multifocal sudden shock-like jerks which are involving the extremities. And this wasn't associated with any autonomic signs. However, these movements occurred only during the sleep and didn't occur during the awake state, and the child was otherwise healthy. So this is the classical video of a neonate with a benign neonatal sleep myoclonus. So here I would be showing some non-epileptic events which we often do get confused with seizures, and all these non-epileptic events are actually age dependent. So So this is a video of a typically developing 10-month-old boy who had this paroxysmal events during periods of excitement. So we can see that there was some sudden tremulous head and the trunk jerk. So this is a classical shuddering attack which occurs in the infantile age group, and it goes away with time. So the seizure mimics are basically age dependent. So there are variant kind of seizure mimics which present differently in neonate, infants, and the children age group. So they can be very stereotypic, bizarre. There are specific triggers like specific event or emotion. It could be it could be suppressible, and this usually stops when distracted. So seizure mimics are a very important part in pediatric population, and we should be aware of all this so that we can easily distinguish it from an epileptic event. So the clinical approach should be a history and examination where we would like to differentiate whether it is an epilepsy or is it non-epileptic, and then we would like to classify the seizure. So the classification of the seizure has already been discussed. So it is basically based on a focal onset or a generalized onset or an unknown onset. And this applies both in the pediatric population as well. However, in case of neonates, like less than 28 days, we do not say seizures without an ictal EEG. So an EEG is absolutely necessary. So without an EEG correlate, we do not label any paroxysmal event as seizure in the neonatal period. So this which could be either an electroclinical seizure or it is an electrographic seizure. So electrographic is where there is a EEG is evident of the epileptiform discharges, and electroclinical there is both a clinical event as well as it has a ictal correlate also. And a special type of seizure which is mentioned in neonate apart from the motor and the non-motor is basically the sequential seizures. So what happens is that in this form, a neonate starts with maybe a clonic seizure, eventually evolves into a tonic, and later on it may also evolve into a spasm. So there are various semiology of seizure which are clustered in one seizure type. So those seizures which basically we call it a sequential seizures. So coming to the evidence from the literature about this misdiagnosis rates, so it is around 4.6 to 30%. It is even more common in the children, which ranges from 24 to 47% of all the referral cases are admitted with the first seizure, which is diagnosed as non-epileptic event. So almost 20 to 50% of the children who are diagnosed with a epileptic event, like referred with epileptic event, are actually non-epileptic events. So we must be careful about all those seizure mimics. And staring spells form the most common type of seizure mimic, followed by the psychogenic non-epileptic events or breath-holding spells. In adult, the proportion is less, like 6 to 19%, and the cardiovascular syncope is the most common cause. So to differentiate the epileptic from a non-epileptic event, we should always focus on a good clinical history. We should avoid unnecessary investigations and don't over-interpret EEG findings, because in infants and in neonates, there is often a very gray zone between whether it's a seizure or not a seizure sometimes. So that times we do ask for an EEG. And if still the diagnosis is certain, then rather than starting any anti-seizure medication, we should carefully follow up the patient, and we may ask for collection of more home videos. So now coming to whether this is a provoked seizure or an acute symptomatic seizure versus an unprovoked seizure. So so there was a case of a child who was 7 years old, who was a case of chronic kidney disease. He presented with the first episode of generalized seizure. He also had some motor delay. The BP was normal. There was no focal deficits. On investigations, he had a hyponatremia. However, the calcium, glucose, everything was normal. An urgent CT was advised, but it also turned out to be normal. So in this case scenario, so it looks like a provoked seizure due to a metabolic cause like a hyponatremia. So provoked seizures can also be due to drugs, toxins, and the clues that it is a provoked seizure basically comes from the underlying chronic medical conditions like diabetes, kidney disease, or exposure to any specific toxins in the young children, or there can be some abrupt drug withdrawal which may also lead to a provoked seizure. And the phenotype is usually a generalized seizure. However, even before the onset of the seizure, there is definitely some altered mental state which lasts beyond the postictal period in a case a child is presenting with a provoked seizure. That means it is not only the seizure, there is also involvement of the neuraxis, so there is some cerebral dysfunction also. So what do we do in this case? So we obviously order for investigations like the routine baseline investigations, glucose, electrolytes, renal function and liver function test, and urine toxicology. And treatment-wise, we do correct the underlying cause. Like in this child, the child had hyponatremia, so a sodium correction needs to be given. And most cases, the anti-seizure medications are not needed. We treat the underlying cause. So now coming to another case where a 2-year-old boy with fever and vomiting for 7 days, followed by altered sensorium, presents to the emergency with the first episode of right focal seizure. In this child examination, we found that he was encephalopathic. There were meningeal signs were positive. There were hemiparesis. Investigations showed that the electrolytes were normal. However, the CT scan showed that basal exudates were there. There were tuberculomas, and there was hydrocephalus and evidence of raised ICT. So in this case, this is basically acute symptomatic seizure due to an acute brain process like a encephalitis, stroke, or traumatic brain injury. And obviously, when we get other neurologic findings which are indicating that certain area of brain is involved, then we can label it like an acute symptomatic seizure. And usually the seizure localizes to the area of brain involved, and it is usually the focal seizure. So in this group of seizures also, we target our investigations to the etiology, and we always do an imaging, because this is a focal seizure, the child is encephalopathy, there are obviously neurological findings on the examination. We definitely ask for urgent imaging. And treatment, apart from treating the underlying cause, like it could be a tubercular meningitis in this situation. So apart from treating with the anti-tubercular drugs, we also start the child on anti-seizure medications, but this is for short term, that is till the duration of the underlying illness is there. So after coming that, if the child is having a provoked seizure, so we don't find a history of an acute brain insult, we don't find a history of any other provoking factors. So we want to know whether this is the first seizure of epilepsy, a new onset epilepsy. So many a times it happens that a significant minority of the patients presents with a unprovoked seizure, but there is definite history of the previous seizures, like in case of a juvenile absence epilepsy or a juvenile myoclonic seizure, where usually the parents come when there is the first convulsive episode. And in that case, we should take history from the parents regarding whether any previous seizure episodes like drop of objects in the morning, in the morning hours, unresponsive staring episodes, or there are some nocturnal events. So like sir has showed in the previous case, so this was a similar case of a girl who had presented to OPD with a first convulsive seizure. But there was, on inquiry, there was history of some staring episodes since last 6 months, and there was decline in the scholastic performance. But however, the EG showed that there is a classic 3 Hz spike and wave which is generalized and which is anterior dominant. So this was the classic case of a juvenile absence epilepsy. So when we get a unprovoked seizure, so we want to know that what type of epilepsy it. So ILE has given a classification for various epilepsy types like focal, generalized, combined, generalized and focal, and unknown onset. So ILE in 2022 has actually classified all these epilepsy syndromes which are age dependent, and at this point I would just like to say that many of the epilepsy syndromes in children, like approximately 25% cases are basically a developmental and an epileptic encephalopathy, where the underlying genetic mutation actually affects both the development and also causes the frequent seizures, which leads to an encephalopathy. So there are various etiologies, like it could be structural, it could be genetic, it could be infectious, metabolic, immune, or unknown. So developmental and epileptic, apart from the most common could be the febrile seizures. Then after that it is genetic causes of epilepsy, very common in children. And many a times it could be genetic plus structural, like in a neurocutaneous syndrome like tuberous sclerosis, or it could be genetic plus metabolic like a GLUT1 deficiency. So when we are sure that okay, it's a seizure, so now we would like to see order a set of investigations, and then we would see whether the anti-seizure medication is needed or not. So there is a recommendation to do EEG in both children and adults with an apparent first unprovoked seizure, and it has been seen that approximately 18 to 56% of the children has epileptiform abnormalities on EEG, and the routine EEG protocol what we follow is an awake sleep with activation procedures. The timing is best to do within the first 24 hours, but a child who recovers to a baseline neurologic status following a first seizure and is otherwise well, he may not need an urgent EEG, and an OPD basis EEG is sufficient. And we should not be, we should take care to overinterpret the normal variants as epilepsy. And EEG basically assists in the first seizure with the determination of the seizure and epilepsy type, and it informs the choice of further investigations. For example, if in EEG we get a focal slowing at particular area, then we would like to see if there is any underlying structural cause. And of course, it gives the prognosis regarding the risk of seizure recurrence. So it has been seen that the risk of recurrence in children with first seizure with a normal EEG is 27 to 42%, and with epileptiform abnormalities it's 60 to 71%. So coming to the neuroimaging recommendations, so non-contrast CT presenting with a first seizure, particularly in children who have abnormal neurological examination, preceding history, predisposing history, like could be history of some fever, headache, vomiting, or a focal seizure onset. In those scenarios, a non-contrast CT is needed. ILE Neuroimaging Task Force has also advised of an epilepsy protocol which should be done after the first seizure. And all patients of epilepsy should undergo MRI, except like when there is a definite genetic generalized epilepsy, like in case of a classical absence epilepsy or juvenile myoclonic epilepsy. At upfront, we don't need a neuroimaging. And sometimes it happens, we do suspect a structural etiology in a child, but because of the ongoing myelination, we may not be able to detect. So we should always repeat a MRI in a child who is more than 2 years of age and who has persistent seizures, and we are still strongly suspecting, okay, there is an underlying etiology. So there are many other investigations like routine blood investigations to look for the provoked ones. Lumbar puncture is done in a setup of a clinical infection, and genetic testing is usually not recommended for first seizure, but there are many genetic causes, so we should also keep a high. I just end up in just 2 minutes. So coming to the treatment consideration, so when a child presents with the first time with a seizure, so we should stabilize the child and abort the seizure with benzodiazepines. Then we should do a history and a focused examination and simultaneously assess the need for the urgent neuroimaging and the investigation. So first we would rule out a non-epileptic event. So if there are history of a fever, so if the neurological examination is normal and otherwise the child is healthy, so mostly it could be a febrile seizure. Otherwise, if there is an encephalopathy or some neurological findings, it is an acute symptomatic seizure. So here we would treat the cause and give anti-seizure medications for short term. And in case of provoked seizures also, we should treat the cause. And then we should decide the need of long-term anti-seizure medications with an EEG and MRI. So what it is routinely said that for the risk of recurrence, that it is more common with when there is epileptiform abnormalities, there are epileptogenic lesions on MRI, there is an abnormal neurodevelopment, there is a remote symptomatic etiology or a nocturnal seizure. So for the first seizure, unprovoked if it is, so anti-seizure medication is usually not needed with a child who is neurologically normal and the EEG and the MRI is normal. However, every child should be having an individualized, and we should develop an individualized approach for this.
Thank you, Dr. Chaudhary.
Yeah.
It was quite an elaborate review on how to deal with the child with the seizures. The house is open for any comments. I think she's given a very broad review as to which patients have to be treated. The most important thing is that childhood epilepsy is associated with number of psychological, emotional issues. So the first point is whether the child has a seizure or it's a seizure mimic. So she has elaborately talked about it. Anybody else wants to discuss anything with Dr. Chaudhary? Thank you, Dr. Chaudhary. It was a nice talk.
We must thank Dr. Chaudhary for very elaborate talk. We are thankful to you.
So may I request the chairperson to honor our speaker and have there is a long applause for Dr. Seoni. Punjabi wala hath. Can I request Dr. Alok Lal to honor me to be on the dais to honor the speaker? Dr. Alok Lalnani is currently the president of IMA Jalandhar. May I request Dr. Vineet Mahajan and Dr. Atul Agarwal to honor the chairpersons with a pot of plants. Thanks a lot, sir. Big round of applause for our chairpersons. Thank you, sir. We are honored. So we have now the time for So we have the time for the third lecture of this evening by Dr. Prashant Jory on febrile seizures. So may I request Banda and Kavaljit to escort the chairpersons on the dais. Dr. Manish Singhal, Dr. Kunj Lalwani, Dr. Mayank Kobrai, and Dr. Tandon. In fact, we have 5 lucky draws also along with 1 punctuality prize for this evening. So let us see whose luck favors today as the first lucky person. So I will be requesting the chairperson to pick up one of the names from the pot. Can I have the pot, please? So would you mind picking up one name? And just you can announce the winner also. Dr. Parvind Dhingra. So first lucky draw result goes to Dr. Parvind Dhingra. So big round of applause for Dr. Dhingra. So you can collect your prize from us. So may I request the chairperson to invite and introduce to the audience our honored speaker for this evening, third session, Dr. Prashant Jory. Banda, please escort the speaker on the dais.
Good evening, everyone. So after two wonderful presentations, now we are going to have a very interesting talk on febrile seizure. And the faculty for this topic is Dr. Prashant. He did his MD from KGMC Lucknow and DM Neurology from AIMS. He has more than 80 publications to his credit and has contributed about 24 chapters in various textbooks. Not taking much of the time, I invite Dr. Prashant Jory to start his deliberations.
Thank you, sir. Am I audible? So thank you, Dr. Sandeep and the whole organizing team for calling me. It is indeed a pleasure for me to be here. I was able to meet my old friends and then catch up with everyone. So the topic that I was given is febrile seizure. The presentation slide. Okay, so how many of you are involved in caring for children? How many of you are pediatricians or are actually looking after kids? So there are quite a few. So let me tell you that, or let me start by saying that even if you are not caring for kids, this is one topic about which you should actually be completely aware of. What is the recent advances, how to diagnose them and how to manage them. Because it is actually one of the most common reason why a child will have a seizure or will come to you, especially in that younger age group of 6 months to 5 years of age. So febrile seizure is one important topic, and why I say this, because the prevalence is quite high. It has been reported from the Western studies that 2 to 5% of children will have a febrile seizure during this age group. And in our Asian population, in fact, it is actually slightly even more. So up to 5 to 10% of our Indian kids can have a febrile seizure during this age. Now this actually has a peak incidence of between 12 to 18 months, though the age group is 6 months to 5 years. So this is the age group where it is commonly occurs. Now we all know that febrile seizures is generally benign, but then a subset can actually be a first presentation of an underlying sinister disease or sinister epilepsy or a genetic epilepsy. So we need to be quite clear what are the recent advances that has come up. How do we actually approach febrile seizure in 2022? So let us come with to the first question. How do we diagnose febrile seizure? So there has been multiple definitions that have come up. They are more or less the same. So what they say is that we call someone to have a febrile seizure when we have a child who is 6 months to 60 months of age, who comes to you with a seizure associated with a febrile illness, that is where the temperature is more than 100.4 degree Fahrenheit, and this fever is not because of a CNS infection. The child doesn't has any previous history of any neonatal seizures or any previous unprovoked seizures, and is not meeting a criteria for acute symptomatic seizures. Thanks to the previous speakers, now these terms unprovoked seizure, acute symptomatic seizures are all clear, so I'll not go into detail of it. Now there is slight differences in the various bodies. Now once febrile seizure was actually recognized way back in 1980s, so there the definition started that this was classified by NIH as a seizure which occurs after 3 months of age. Then there came a classification by ILAE in 1993, which said that we can diagnose febrile seizures between 1 month to 5 years. But the recent consensus by American Academy of Pediatrics, which has been adapted world over, is that we diagnose febrile seizure between 6 months to 5 years. So in the process, I'll let you know why this 6 months age group was chosen. So what is actually a febrile seizure? Is any seizure happening along with fever in this age group should be called or labeled as a febrile seizure? So generally this name is given when we have a short-lasting generalized seizure, mostly less than 5 minutes, classically described as less than 15 minutes, which is happening at a single time within 24 hours of a fever onset. Mind you, this fever is not because of a CNS origin. Now this is mostly has got peaks. Understandably, if you have more of viral infections as you have in winter months, URI, you will have more febrile seizures. In summer months, along with gastroenteritis, can have fever, and then there would be a peak of febrile seizures in this age group, in this time as well. So what we have is this classical description is of a simple febrile seizure. And this simple febrile seizure constitutes almost 65% of the cases who come to us as diagnosed as a febrile seizure. So all this benign nature that has been advocated by everyone is related to these simple febrile seizures, where you don't have to do much except for counseling the family. Now, there are other variants of febrile seizures also we need to be aware of. These febrile seizures can be complex febrile seizures, or sometimes they can come with a very prolonged seizure, like a status. So this is diagnosed as a febrile status epilepticus. So this complex febrile seizures, they constitute almost 30% of these cases. And what are these complex febrile seizures? They can have either of the three characteristics that have been shown to you. So it can either be a prolonged seizure, it can be a focal seizure, or it can happen multiple times within the same febrile illness. If any of these things are there, then you are not dealing with that so-called benign simple febrile seizure. And you have to have your tentacles upright, that maybe you are dealing with something in addition, something which is superimposed on there, and you have to be a bit more alert on it. It doesn't mean that you have to straight away start treatment, but you just have to be a bit more alert. And the same is true for those 5% of cases who comes with febrile status. So sometimes you can have the first febrile seizure as a status. The definition is all known to us, that a seizure which is lasting more than 30 minutes or recurring within 30 minutes without any gain in consciousness is a febrile status. Now, some of them can have prolonged unconsciousness, where it can be a non-convulsive status. I'll not talk about that in detail here. So, because we want to start treatment of them, so we have to have some idea which child is actually going to have a febrile seizure. So, there has been a lot of interest among researchers. People have done a lot of epidemiological studies, and they have identified that if you have a family history of febrile seizure, if there is a seizure which is happening in a child who has got a neonatal admission for more than 28 days, or there is a child who has got developmental delay, or has been going to daycare settings for quite a prolonged period during the infancy phase, this is a subgroup where the chances of having a first febrile seizure is high. So if you have a doubt and you have all these features or some of them, then the chances of having a febrile seizure actually increases from that 5 to 10% to almost up to 28%. There has been some other risk factors which has been identified, but they are not major. So there can be some micronutrient deficiencies, but mind you, you don't have to start investigating for them just to get to a etiology of febrile seizure. So it is just for your knowledge, but you don't have to start investigating for them. So pathophysiology, I'll not bore you with this, but then this is a age-limited, temperature-dependent seizure susceptibility state. So what happens is that these kids who have fever, they have the increased body temperature, which actually acts as a excites the neurons to an extent which crosses the threshold to throw a seizure. There happens some hyperventilation which causes alkalosis, and the same thing happens. Third is that there can be some cytokine release which are excitotoxic to the brain. Now this is happening in every child who has got fever, but we know that only the 5 to 10% are developing febrile seizure. So what is the reason behind it? So now with advent of so much of genetic information, now we know that there is a genetic susceptibility which is causing the brain to behave in a different manner to a fever, to a precipitating factor such as fever. So genetics has come a long way. Now we know that majority of these kids have a family history suggestive of febrile seizure. Almost 20% chances there if you have a affected sibling as a febrile seizure. You have 33% chances any of the parents have a febrile seizure, and the inheritance is actually polygenic. So there are multiple genes that has been identified, but the most common that we should also be knowing is the sodium channel genes and the GABA B receptor gene. So these are two have been most commonly associated with a predisposition to febrile seizure. So what is decides the management? So do we need to investigate all of them for these genetic etiologies? No, we don't, because this is not going to alter the management. So what does alter the management, or how do you decide management? So it is decided by the possibility of recurrences. But anyway, we are only trying to withhold, we are only trying to stop the seizures from happening. This is what we do in any other epilepsies. So here also, if you think that you want to stop febrile seizures from occurring, we need to know the recurrences. So this is the data which has come from a recently published Denmark study from JAMA. So they have identified that if you have a first episode of seizure, then the recurrence of febrile seizure is there in almost a fourth of a patients. So 25% patients can have recurrence. If you have 2 febrile seizures, then it is almost 33%, that is 1/3 can have a recurrence. And if you have more than 3 febrile seizures, then the recurrence chances are up to 50%, more or less of 44%. So this is how the chances of recurrence are there. Now the question will come whether you actually want to treat these febrile seizures, you want to stop these recurrences from happening. And if you want, then why do you want to do so? So I'll come to that later, but let us first know that what are the risk factors that are associated with these recurrences. So again, with studies now we have known that the most strongest risk factor is again a family history of febrile seizure in the family. And if your first febrile seizure has happened very early into the age, say less than 12 months or less than 18 months. So these two are the most strongest factors that tells you that possibly your child has going to have recurrent febrile seizures. The other factors that are there, that if you have the peak temperature quite low, which actually excites the brain to throw a seizure, then the chances of recurrences are high. If the duration between the fever onset and seizure is short, then also the chances of recurrences are high. So these are the 4 risk factors that you need to know that are associated with increased recurrences. So let us now come to the diagnosis of, or the differential diagnosis. So what will actually happen in a routine setup is that a child might come directly to you seizing in your ER, or he comes to you in your OPD for a second opinion, that the child had an event a few days back, now what has to be done. So if he is coming to your ER, then you have to also have your set of differentials ready, that are you actually dealing with a febrile seizure or it is something else. So on the left you have all these benign differentials, that they can be sometime breath holding spells or febrile myoclonus, or the kids can get actually slightly delirious during that phase, but all these will be bizarre activities. They will not be stereotyped as a seizure is. So you can easily actually differentiate if you have understood what Dr. Shiny was telling you. There was a discrimination between the seizure mimics and the seizure. So febrile seizure is a true seizure. So it will have all the properties of a true seizure. So these differentials on the right, they are more sinister ones. So these are epileptic disorders, known as, some are fever triggered, which are called fires, nausea, some are genetic epilepsies. We are not going to get into details of this. If you have a question, I'll be happy to answer that. So what is the key thing that we want to differentiate is a CNS infection. That is the only thing I want you all to be interested in. So so we know that what are the basic clinical features that suggest a CNS infection. You will have an invasive disease, you will have a prolonged course, seizures occurring after 3 days of illness, you have focal or a prolonged seizure, your examination findings will suggest focal deficits, loss of sensorium which is sustained. So all these things, or a bulging fontanelle in an infant. So all these things will give you a clue that maybe you are dealing with a CNS infection, and then you have to go ahead with a certain set of investigations. So what is the diagnostic evaluation or the set of investigations that we should actually be doing these days? So there are a couple of recommendations that are there. So there is one from American Academy of Pediatrics that has come in 2011, and there is one Japanese guideline that has come in 2015. So I've taken one Western and one more Eastern countries guidelines which are quite followed all over the world. So the crux of them is that they say that yes, febrile seizures are benign. A lot of investigations are actually not required, but now we will try to tease out that which subset will actually not go with this concept of febrile seizure being completely benign. So I'll try to tease out when actually you need to do an investigation. So there are three major investigations that we talk of in seizures, especially when in the context of febrile seizure. First would be a lumbar puncture, second would be an EEG, and third would be an MRI. So when do we do a lumbar puncture? So lumbar puncture, we all know that we want to differentiate it from a bacterial meningitis, and that is why we want to go ahead with that. So what the recent data has come, that after the Hib vaccine that has got introduced in India in 2011, the risk of bacterial meningitis has slightly actually come down. In the world, it has already come down. So there has been a change in approach to febrile seizure as far as lumbar puncture is concerned. So the American Academy of Neurology Pediatrics, they say now that you don't require to do a lumbar puncture in a child which is well appearing, is fully immunized, and has got a simple febrile seizure. So you have to be sure that he has these three things there. He is completely immunized, the child is appearing well otherwise, and has got a simple febrile seizure, not a complex or a febrile status. So they say that you have to do lumbar puncture when you have frank meningitis. We all know this, but they also say that it can be an option that to go ahead with a lumbar puncture in age group of 6 to 12 months when you don't know about the immunization status, especially about Hib and pneumococcal. Or you go ahead with a lumbar puncture when the child has already received antibiotics and then has come to you. So in those the two settings, the American Academy of Pediatrics recommends. The Japanese guidelines suggest that you do lumbar puncture only when frank signs of meningitis are there, and they have laid down those signs. They say that if there are signs of meningeal irritation present, then you go ahead. When there is an altered sensorium more than 30 minutes, then you go ahead, or there is a bulging frontal limb, then you do a lumbar puncture. So the question is, what is the implication for us? Neither we completely, our society doesn't come in completely like a US, neither it behaves like Japan. So what we do at AIMS here is that we do lumbar puncture in children who are less than 6 months. Why we do that? Because the chances of having febrile seizure less than 6 months is quite low. The chances of infections mimicking febrile seizure is high because the sensitivity of those signs of meningeal irritation, the neck rigidity, kernicks, these are actually less at this age. And secondly, genetic epilepsies presenting as first seizure, especially post-vaccination, is high. So we have chosen to do lumbar puncture in any kid who is less than 6 months. Between 6 months to 12 months, we have laid down a criteria when we will go ahead with a lumbar puncture. So we do that when we have frank signs of meningitis. We all do that. But we also do when the seizure has occurred more than 48 hours. So I have already told you that a febrile seizure actually happens within 24 hours of seizures, fever onset. So if you have a seizure which is happening more than 48 hours, the chances are more that maybe you are dealing with a CNS infection. So you do lumbar puncture in that case. Altered sensorium more than 30 minutes. We have taken it from the Japanese guideline. Or the immunization status is not known to us. Or the child has received IV antibiotics before coming to us, or he has got a complex febrile seizure or a febrile status. So in any of these scenarios, we go ahead and do that. Or because of any reasons, the primary caregiver is not available, or somehow our history and examination is not clear, we are unsure, then we go ahead with this. So this is the scenario where we do a lumbar puncture. Beyond 12 months, we know that the signs are quite clear for meningitis. So once we identify that, yes, there is a possibility of meningitis, then only we go ahead. Now, for EEG, so the EEG actually is done for what? So in any seizure, we do EEG for getting a diagnosis of that syndrome. So in febrile seizure, I would want to do an EEG for establishing a febrile seizure diagnosis, or maybe predicting risk for further febrile seizures, or maybe predicting the risk for epilepsy in future. So truly speaking, there is no EEG marker that can diagnose febrile seizure. So it cannot be used for this. Neither there are any markers which actually predicts further recurrences of febrile seizure or even epilepsy. So none of the three reasons why you want to go ahead for an EEG actually holds true here. So EEG is not required in simple febrile seizure. So when do we do EEG in this? When we have a child with a complex febrile seizure or there is a prolonged febrile seizure is there. Then there are recurrences which are happening without fever, or there are recurrent febrile seizures in a child who is developmentally delayed. Similarly, MRI again does not show any clear-cut picture. Now we know that it is a generalized seizure, especially the simple febrile seizure, so it is less likely to have a structural substrate. So MRI is not indicated in that scenario. When do we do that MRI is mostly when we are suspecting it to be a febrile status or a complex febrile seizure where the neurological examination is abnormal or there is a developmental delay which is already present. Other blood investigations, they should be directed to the cause of fever. If there is burning micturition, you do a urine culture. If there are cough and cold tachypnea, you do a chest x-ray. So according to your presentation, you go ahead with the blood investigations. Treatment, again the treatment is that you should actually talk to the family. So it is a very volatile state. The parents are very apprehensive when the young child throws a seizure. So the thing is that you calm them, you allay their anxiety about you disclose the benign nature of the disease, you tell them what realistically is the recurrence based on the risk factors that I have already described. You educate them about the recovery position, the domiciliary care that has to be given during an episode of a seizure. And what about anti-seizure drugs? So again, people have studied that whether there is a point in reducing the risk of seizures. So if you start them on a continuous anti-seizure drugs, then you will be able to reduce the recurrence of febrile seizures happening, but it doesn't reduce the risk of future epilepsy, which should be the true goal of starting a drug. And then if you are just stopping simple febrile seizures, which otherwise are benign, by a continuous drug, which comes at a cost of side effects, so that would not be cost effective. So the dictum is that we don't use continuous anti-seizure drugs or intermittent anti-seizure drugs in the children with simple febrile seizure. But at times we do use these drugs, and those conditions are when we have prolonged febrile seizures happening more than 15 minutes. So it has been seen that if you have first seizure as a status, then the further seizures are also likely to be status. And that status can lead to SUDEP, can lead to some other major complications. We don't want to have that. So you can either have an intermittent prophylaxis or you can choose a continuous prophylaxis. The evidence for both preventing future epilepsy is weak. So this has to be bear in mind. So generally at our center we use when they have very recurrent febrile seizures happening and the family is coming from a far off place. There are logistic difficulties in assessing healthcare facilities. There is a very anxious family is there or the support system is weak. In those scenarios, we use intermittent clobazam. We use continuous prophylaxis despite of that intermittent prophylaxis, you have seizures happening. There is developmental delay that is already there in the child on which there was a fever-triggered seizures happening, or there are febrile status which are happening frequently. So in those scenarios, we choose continuous prophylaxis, and the drugs then used are phenobarbital and valproate. We don't use CBZ or phenytoin, carbamazepine or phenytoin for this purpose because they have not shown any benefits. Levetiracetam, we don't have much data available, but people are using it. Adjuvant therapy, yes, antipyretics are required, but its role is just to calm the child. It does not again stops a child from having further febrile seizures or epilepsy. The reason why these drugs are not able to stop it because there is a genetic predisposition because of which these kids with febrile seizures, a subset of these kids are actually having epilepsy in future. Because of that, genetic predisposition is not going to change with your antipyretic or anti-seizure drug. So you have to be very clear that all these therapies are not going to stop the kid from having a future epilepsy if the possibility is there. Prognosis is generally excellent, especially for simple febrile seizures, but yes, the complex febrile seizures, they can have future epilepsies in almost 4 to 12% cases. This is a recent JAMA publication which has shown that there are some psychiatric problems that are an increased proportion of in children with febrile seizure compared to general population, but they have included kids who have neurodevelopmental disabilities also. So we cannot actually buy them. So these are the factors which cause future possibilities of epilepsy, and these are the scenarios where we actually start anti-seizure drugs. So it's very simple to understand this. Vaccination, one single slide on this, that because it is quite, people are very apprehensive these days, that a vaccination does not cause any special type of febrile seizure. It is just causing a febrile reaction to which the brain is responding because of the possible genetic predisposition. So if the child throws a febrile seizure because of a vaccination, he can continue with the vaccination. You can just give a break for maybe 2 months or 3 months, but there is no vaccination, it is contraindicated, and it is not causing any add-on damage to the child. This we can actually skip. These are certain scenarios which I would prefer not to talk about. So my take-home message is that yes, the febrile seizures, especially the simple febrile seizures, these are actually benign. You just have to counsel the family. A lot of investigations are not required. But if you identify, based on your history, that he has got a complex febrile seizure or the febrile seizure was quite prolonged, then you better try to go ahead and get an imaging and EEG done so that you can combine the information and decide whether the possibility of future epilepsy is high here. And in those scenarios, you need to continue with anti-seizure drugs. Thank you.
Thank you, Dr. Prashant, for a crisp, clear update on febrile seizures. The house is open for discussion. We can take one question. Dr. Rhoda, sir.
Thank you, doctor, for giving such an exhaustive talk. Now, you are talking about investigation. You are talking about American Academy and Japanese study. What they are talking is of pyogenic meningitis.
Yeah.
But for us, the scenario is entirely different, and we are seeing day in and day out. The most common is, or the more common is, tubercular meningitis, where there is no susceptibility. The number one. Number two, you talked about MI. Now, in MRI, simple febrile seizure, but if you get medial temporal sclerosis or some heterotropias, then what is the situation like for the man?
I'll take both one by one, sir. So I fully agree that tubercular meningitis is one common feature. But if you go by the literature, the Indian literature, that how many TB children are going to have seizure on day one of fever, that is the crux here. None of them will have. Because meningitis is an affection of meninges, not the brain. So in truth, this should not cause a seizure very early into life. If very early into the illness, a meningitis is causing a seizure, then it is because of some electrolyte imbalance or other systemic abnormalities. Only later, once complications set in or the encephalon gets affected, then only a seizure would happen. So this affection of encephalon or raised ICP, it takes time in TBM. If your history and examination is clear that your seizure has happened within 24 hours of fever, then the possibility of TBM is almost negligible. And what we are doing, where the signs of meningeal irritation are quite murky, it is not clear, that is the age group between 6 to 12 months, we go ahead with a lumbar puncture in the specific set of scenarios which will actually tell you whether you are dealing with any form of meningitis, TBM, aseptic meningitis, bacterial meningitis, whatever. Now the second question is that, so generally these heterotopias and all, these are focal structural abnormalities. So we have seen, also have our experience of occasionally somehow getting an imaging and identifying that we get a heterotopia there. But majority of these kids are actually having a complex febrile seizure. And what happens here in India or almost everywhere, the onset is not talked about. So what we have discussed in the morning, the focal or the generalized, is not dependent upon what you have seen. It is dependent upon how the seizure has started. So many a times the mother would tell कि मैं जब उठी देखी बच्चा हिल रहा था. That doesn't mean that the onset was like this. So you have to ask clearly, आपके सामने शुरू हुआ था या नहीं? If there is a onset which she is able to tell you, you will be able to make out that there was a staring towards one side, or there was a flickering of lip movements towards one side which started that. So you have to, all these words, if you go in detail in all the previous presentations, they say focal onset epilepsy, generalized onset epilepsy. So that thing is actually what is required, as Gagandeep sir has said, that your clinical acumen is important. So that has to be there. If you are able to identify the two, you will not have issues and you will not need an imaging at that time. I think I have made myself.
So you mentioned about continuous prophylaxis.
Yeah.
So how is it different from a prophylaxis in a epilepsy and all?
No, it
and
is the
how
same.
long will it be? How long will it be?
It is the same, but what I wanted, so I went through them I ran through those slides. So continuous prophylaxis is what we do in epilepsy. Now what is there in febrile seizure is that it is actually not recommended, because people have done a lot of studies and they have seen that yes, if you start valproate on a daily basis, it would reduce the chances of throwing a febrile seizure up to next 36 to 48 months. But the possibility of having an epilepsy beyond 5 years doesn't change in the group which has taken a continuous prophylaxis as well as compared to a group which has not taken a drug. So they say that because it is not stopping epilepsy, why you want to give anti-seizure drugs, which comes at a cost. Any drug you name it, it has significant side effects. So why I want to continue with those side effects? Now what we do is that in the scenarios where the parent is coming from a far off place, very anxious, multiple febrile seizures happening, so we may choose an intermittent prophylaxis. Now again there is a caveat there. If the onset of fever and the occurrence of seizure is very short, the parent will not be able to give that clobazam. So you have to identify that is not going to be a subset where you should give intermittent prophylaxis. Intermittent prophylaxis means that at the time of fever, you give clobazam for 2 to 3 days. So that is intermittent prophylaxis. Continuous is that you continue the child on anti-seizure drug.
In a child with developmental delay, as you mentioned, on continuous prophylaxis, still would your choice would be this drug which you mentioned, phenobarbital, and if you are using it,
so now with
how long
more and more
what is the
information
side
that is
effects?
there and more choices coming, phenobarbital has got out of phase because it comes with a lot of other issues. So valproate would be a preferred choice here rather than choosing a drug which has got a sodium channel effect. So sodium channel blockers like phenytoin, they have been shown that they are not actually very effective in controlling febrile seizure. So you can use topiramate, you can use valproate, you can use levetiracetam. Though we don't have a data is available with us, maybe Dr. Goraya can want to add something to that usage of other drugs here. But even if there is a developmental delay, but these are all fever-triggered seizures, we would choose these drugs, which are effective in both the states.
Thank you, sir. I think we can take more questions on one-to-one basis. Thank you, sir, for a great talk.
Thank you.
It was pleasant listening to you.
So, can I request the chairpersons to facilitate our speaker? And please round of applause in Punjabi way. Dr. Prashant, can you be on the dais, please, again? I also request Dr. Atul Agarwal and Dr. Vineet Mahajan. Please honor the chairpersons with a pot of plants. Thanks a lot for your valuable time, sir. A big round of applause again for this session. And our next session is by Dr. J.S. Goraya. He is going to talk on seizure mimics in children. May I request Bandha and Kawaljit to escort the chairpersons for this lecture, Dr. Sarvinder Singh, Dr. Sumit Chopra, Dr. Gautam Chawla, and Dr. Rohit Chopra. On the dais, please. And I also have the honor of welcoming our chief guest of this today event, Dr. Raman Sharma. We are indebted for your presence here, sir. Thanks a lot. May I request the chairpersons to introduce our honored speaker to the audience.
Good evening. It's an honor to introduce Dr. J.S. Goraya. He is a professor of pediatric neurology at the DMC Hospital, Louisiana. Published more than 100 papers. He's a fellow of the Royal College of Physicians of Canada, fellow of the Royal Society of Medicine in UK. He's a member of IAP, neurology chapter of IAP, AOCN, and above all, he's a good friend of Jalandharites.
All right. Thank you, Dr. Surendra, and other dear friends sitting there as chairpersons. And thank you, the organizing team, Dr. Sandeep Goyal and his team, for inviting me here. Jalandhar is my second home after Ludhiana. Maximum number of my friends are from Jalandhar. And you rightly said, I'm obliged to be here. Thank you very much. Too much of seizures. Let's take a break from seizures. It's not going to be a tea break. It's a break otherwise. I'll be talking about what looks like seizures, can be confused with seizure, but is not seizures. And there are going to be a lot of videos. Some of those videos you have seen. So they are kind of, I've tried to give 2 videos of each kind to show you some differences and also to reinforce the idea that there are certain entities which look like seizures but are not seizures. So we should not be misdiagnosing them as seizures and treating them as seizures or investigating them as seizures. It's going to be a very simple talk, some brief introduction about what the seizure mimics are, what is the classification, and what are the common examples we come across in our clinical practice. And I'm sure having seen a video is going to stay in your mind and is going to help you when you go in your clinical practice. These are some other names for seizure mimics. We call them as epilepsy mimics, seizure lookalikes, non-epileptic seizures, non-epileptic spells or events, non-epileptic paroxysmal disorders or paroxysmal non-epileptic disorders. These are different names used in literature, but they mean one and the same thing. So by definition, these are the clinical events which look like seizures but are not seizures. So that's why we call them as seizure mimics. And it's important to know them because we can, if we are not very careful, if we're not paying attention, we can easily misdiagnose them as seizures. They look like seizures from a point of view of clinical manifestations. They have when you see the videos, you will see that they have the same kind of motor, sensory, cognitive, autonomic, or emotional manifestations as you see with the seizures. But very important, and probably the very important point is that there are no EEG changes or brain physiological changes associated with these events, which you see in a patient who actually has a seizure. And unlike seizures which arise from brain, they can arise from other body systems outside the brain as well. They are very common and maybe more common than actually seizures or epilepsy. It's not a single disorder that I can tell you that this is one entity which you can diagnose as seizure mimic. No, there are a group of disorders, like epilepsy is a group of disorders. So, but each is a very distinct entity, and if you look at it, you will never forget it for the rest of your life. And it has been referred to in the previous talks also, and the first time seizures may actually not be actual seizure. In 25 to 30% of the cases, it may be a seizure mimics, but misdiagnosed as epilepsy. They are age dependent, has been already talked about. Why do you want to learn about them is because most of them are diagnosed on clinical grounds and don't require any investigations of any kind. And you will see that when you look at those videos. Unfortunately, they are self-resolving, being age dependent. They start at certain age and disappear over a period of few weeks or few months. In this study, where the primary diagnosis was epilepsy, which was a diagnosis at referral, it was found that 23% did not have epilepsy. So almost one-fourth did not have epilepsy, and another 12% had even where diagnosis of epilepsy was kind of disputed. So between 1/4 to half of the patients can have non-epileptic events presenting as seizures at the first presentation. So there are chances of misdiagnosis are very high. In a pediatric clinic, which is called Fitz, Faints and Funny Turns Clinic, a clinic in UK, where they evaluate patients who present with these events, and they found that out of 380 children who were evaluated in that clinic, 42% had either syncope or a breath-holding spell, though they were referred with the diagnosis of to rule out seizure. So they are common phenomena, and they must be looked for in any child who presents with first seizure or with seizures. And similarly, in a refractory epilepsy clinic, at least 1/4, 26% with refractory epilepsy clinic, which means they were on multiple anti-epileptic drugs, being treated probably by a neurologist, and even then when they were investigated, they were ultimately found to be having non-seizure events or seizure mimics. Now, reasons to misdiagnose, why do we misdiagnose those events as epilepsy is, other than that they have the same kind of clinical manifestations as those of seizures. The more important reason is that there is lack of awareness that these entities exist. They require a very elaborate history to find out that what happened to the child, under what circumstances it happened, were there any triggers. It was talked about in the previous lecture, and that requires time. You need around 10 to 15 minutes of time to go into, and if you have a busy clinical practice, you may not be able to spend that much time and make a correct diagnosis. The other reason we misdiagnose them, that because of similar clinical manifestations, we equate that any loss of consciousness or any abnormal body movements is a seizure also, otherwise, at least in our clinical practice, if you are not very careful. And other thing which, in my experience, the reason for misdiagnosis is that for these events, somebody got an EEG done from a place, and EEG was reported as suggestive of generalized tonic-clonic, as suggestive of seizures, and we said it's a epilepsy. No, it's not epilepsy. The diagnosis of seizures is clinical. If patient has seizure, EEG will help you corroborate the diagnosis. Dr. Gagandeep said very eloquently that the abnormal EEG does not mean seizure or epilepsy. The diagnosis is always clinical. And lastly, we all have a tendency to give a diagnosis to a patient who comes to you for any illness, even if it is a fever. So here we have a tendency to give, even if we are not very sure that patient has seizure or not seizure, we tend to give a diagnosis. And easiest thing we normally tend to do is to tell the parents he's got epilepsy. That's my experience also from a clinical practice. So these are the reasons for misdiagnosis of these events as epilepsy. Now, there is various ways of classifying these seizure mimics. Like I said, some of them are of neurological origin, but they can arise from other body systems, from cardiac arrhythmias can be can manifest loss of consciousness, some tone changes, and can be misdiagnosed. And everyone has had those patients in their clinical practice where the manifestation was neurological, but underlying cause was cardiological or cardiac. Psychological events can manifest. We'll show some few videos. A foreign body in the respiratory tract can cause acute choking and cyanosis and loss of consciousness, and can be misdiagnosed as a seizure. Gastroesophageal reflux is, especially in a very young infants, can manifest like acute life-threatening event with the choking and with the laryngeal spasm and with the loss of consciousness, sometimes can be confused. And in any child who presents with the first unprovoked seizure, we always recommend to rule out metabolic diseases, was talked about again in the previous lectures, hypoglycemia and hypocalcemia. Now, these two, hypoglycemia and hypocalcemia, apparently you see in a normally healthy children in this situation, and you might think that, oh, this is unprovoked seizure, so this should be an epilepsy or epileptic seizure. No, every child or any child, or I'm sure about adults also, first time seizure or seizure-like event, you need to do at least blood sugar and calcium to rule out these underlying causes for acute symptomatic seizures. Now, the most useful classification from a clinical point of view is age-based, because we said that these are age-dependent manifestations in a child. So I would request you just remember a couple of them at each age so that you don't miss. I'll talk about those which are the commonest at those ages. So in neonate, the things which look like seizure are jitteriness or benign neonatal sleep myoclonus. There was a video shown in a previous lecture. Infants and young children, breath holding spell, benign paroxysmal vertigo, benign paroxysmal torticollis, almost similar disorders, shuddering episodes, you saw the video, gratification, you saw the video, and Sandifer syndrome. Older children and adolescents, syncope, pseudo seizures are the two commonest things which are misdiagnosed and mistreated as epilepsy, but there are of course many others which are there, but not as common as these two are. This is the whole list of about 40 odd disorders which can manifest with as seizure mimics in infants and young children, older children, and adolescents. But I'll be focusing on just these few. These are these 8 disorders probably account for 80% of the seizure mimics in the clinical practice. So if you remember all these, you will be able to help 80% of the time for a person who is presenting with a first seizure. So here begins now the video journey. 2-day-old infant, full term C-section, and was normal birth weight, no birth asphyxia, feeding well. And on day 2, he came with these tremulous movements. 2 videos, I'll play them together because, oh, sorry. That's what happens sometimes. Is the reason the video is not projecting? हाँ, पर क्यों नहीं आ रहा? Let me check another video. So sad. Okay, so I'll use the alternative way of looking at the videos then, and shows you those videos which are important. Sorry, this is not the video. Yeah. उधर नहीं चल रहा? Everything is in the computer. Swati region remote. Will it work on these slides itself now? Okay. Sorry. Yeah. No, there's some problem. No, they were added. I just kind of did in the last. So let me go there. It can work here. So jerky movements of extremities. So can be easily confused with a seizure, but this is not seizure. This is benign unilateral sleep myoclonus. The identification is that it happens only during sleep. Jerks are like myoclonic, random, and if you wake up the child, they will go away. But so sorry, it's going to take a lot of time. So, random intermittent jerks of limbs in sleep. Face is almost always spared. They are exaggerated by rocking movements, and they stop with awakening. But that doesn't mean you awaken the child every time he has seizure, because then you will interfering with child's sleep. The EEG is normal, whether it's interictal or ictal, and they resolve in few weeks. Normal neurological outcome, there is no investigation required, and there is no treatment other than reassurance that these jerks are going to go away. This is our own data. So 18 patients we saw over 5 years, and majority of them were misdiagnosed as neonatal seizures. 15 out of 18, and remaining 4 were suspected to have sepsis meningitis, 2 with inborn errors of metabolism, and 2 with myoclonus. They were extensively investigated. But just look at their clinical presentation, we were able to make a diagnosis. Now, this 2.5-year-old girl, she has these spells where she crosses legs, and these are associated with groaning, swearing, sweating, facial flushing, and during these episodes, she appears to be spaced out, and she's not very aware of what's going on in the surroundings. And I'll show you the video. नहीं आ रहा कुछ ना कुछ प्रॉब्लम है somewhere, but I haven't changed computer, I haven't put them anywhere else. Anyway, when embarrassment comes, it comes in plenty. Okay, I'll just go through the videos and then talk about it. I think that's better than going into slides. Okay. So depending on whatever age it is, so I'll show you So it's coming. Let the video come at least. Just videos. Because this talk is all about videos. On the way. So this young infant has these episodes where he becomes stiff and blue also, and these are triggered by emotional hurt, frustration, or crying. Whatever induces crying, this crying evolves into prolonged expiration, and this child becomes hypoxic, cyanose, stiff, and then have few, sometimes few clonic movements. So this is what? This is breath holding spells. This is interesting. This is a young child again, I think about 2 years of age. He has these episodes where he specifically says, "Chakkar aa gaya." That's his word. And a 2-year-old child saying "Chakkar aa gaya" seems little unusual. And then he's trying to cling to his mother or whatever is available. He doesn't want to move. It lasts for a couple of minutes, and then he's fine. There's nothing post-ictal. He doesn't vomit, and he doesn't lose consciousness. He's a little unsteady. So he has these episodes once in 2 weeks or 3 weeks. He doesn't want to move. He falls, he's little ataxic. And look at eyes, look like little wide open, and he looks anxious. So if these episodes are recurrent, a young child, he himself says "Chakkar aa gaya," and on a family history, mother has a very strong history of migraine. So this is a migraine variant. We call it as benign paroxysmal vertigo. So this is sometimes we call periodic syndromes in young children. So migraine can manifest like these episodes in young children, and when they grow up, can develop real migraine. And a similar disorder is that of head tilt. Almost similar story, young infant has these episodes of head tilt lasting few hours to sometimes couple of days. He has had 3 episodes of like this. And after like this episode's recovered in 6 hours, and he was fine again. During this time, he's slightly irritable and may have a little bit photophobia. So this is benign paroxysmal torticollis. And just because of head tilt, this patient and might be confused with as having an epileptic seizure. And this is spot diagnosis. Stiffening of legs, some shaking or involuntary movements of hands. And she's crossed her legs. And again, misdiagnosed as epilepsy or epileptic seizure. But this is infantile gratification syndrome or infantile gratification. These are episodes which happen several times a day. Whenever a child is idle, she or he will have these episodes. And treatment is distraction. This child has these episodes of stiffening of body and some shaking. He's excited. And now he has these. So he has hundreds of these every day, but he's developmentally normal. So what it is? Shuddering episodes. So my job has been done easy. Let me show you. I'll show you a few more slides and then I'll be done. And this is, see, he's laughing. So what is the easiest thing you can confuse these movements with? Infantile spasms. They look like infantile spasm, but in this situation, child was absolutely normal, no developmental delay or developmental regression. This happen continuously almost, and that's not, they are more on awakening from sleep. So this was again a shuddering episodes, but easily can be confused with infantile spasms here. This child has these bizarre movements. She has some headache, dizziness, and then she says she has some suffocation, she can't breathe, and then sometimes have some thrashing movements of her extremities. She's an adolescent girl, and she has, this episode will last about 15 to 20 minutes, and she has several every day. Any idea? Non-epileptic seizures are psychogenic, non-epileptic seizures are because pseudo seizures are functional. So they're common in adolescent.
I think so. We are running short of time.
I'll just two more videos. I'll be done. I take the responsibility for messing up. So this child not only has these spells, but he also has a frothing, which is and so obviously he got up, and obviously parents were treating it as a epileptic seizure, so that shoe worked differently. And let me see one more video. In the end, you'll like it. I don't want to keep on going because we're running short of time. So you will have to tell me. I don't think it's there. Okay. Chalo. If that is not there, see this one. This a neurologist must be able to diagnose. Abnormal movements, body movements. Okay. He's an adolescent boy. He was okay, but when he started running, after a few seconds of running, he starts having these involuntary movements. So what it is? PKD, paroxysmal kinesiogenic dyskinesia. You want another one, or that's it? I think.
Last one.
Last one, yes. But where is that last one gone, which was very actually interesting and I can't find that. Let me show you. So what it was? Yes? This was also a, okay, I found it. At the last one is, give you a lighter moment. Now you diagnose what disorder this Murga has. What is the diagnosis? Breath holding spells. So we have an animal model of breath holding spells. Thanks to WhatsApp. Thank you very much. And sorry for the snag and whatever happened.
Thanks, Guraya sir, for an extensive talk. I think there are no questions. Videos have depicted very well the seizure mimics.
That's the only saving grace. Okay, thank you.
Thanks a lot for a very nice session, sir. So may I request the chairperson to facilitate our speaker. And Dr. Vineet and Dr. Atul Agarwal, please also join in honoring our chairpersons also. A round of applause, please. Thank you. Now is the time for inauguration ceremony. Can I request Dr. R.S. Bal to be on the dais, please? Dr. Alok Lalwani, can you also join? Please join on the dais. And may I ask Dr. Shubhang Agarwal, Dr. Naveen Chitkara, and Dr. Sanjeev Goyal to escort the chief guest of today evening. Please escort Dr. Gagandeep, Dr. Ashok Kupal, and Dr. Please escort Dr. Gagandeep, Dr. Ashok Kupal, and Dr. Raman Sharma on the dais, please. We can welcome them with a clap, please. We welcome Dr. Malabhaskar also. I think he has traveled the farthest from Bangalore, so a round of applause for him also. Can we have the music, please? Can I request to Dr. Shubhang, Dr. Naveen Chitkara, and Dr. Sanjeev Goyal to give the memento to our chief guest today? And the gift also, please. First of all, please honor Dr. Ashok Kopal by Dr. Lok Lavlani, please honor Dr. Ashok Kopal. Please honor Dr. Raman Sharma. He is the civil surgeon of Jalandhar. Thanks a lot for sparing the time for us, sir. Thanks a lot, sir. So then there is a next lecture session by Dr. Parampreet. He is speaking on the choice of anti-epileptic agents. Can I request Bandana and Kavalji to escort the chairpersons for this lecture session? Dr. Tarun Agarwal, Dr. Taranveer, and Dr. D.R. Sharma, and Dr. Vinay Malhotra. May I request the chairpersons to introduce the next speaker, Dr. Paramjit Singh.
Good evening, friends. Potassium bromide was the first medicine introduced in the year 1857. Since then, anti-epileptic agents have traveled a time period of 165 years. New medicine have been added since the last 2 decades. To tell us about the choice of anti-epileptic drugs, we have with us a neurologist of classical mold, a trendsetter. He is a bibliophile, lexicographer of neurology. Please welcome Dr. Parampreet Singh Thundust.
Thank you, sir. Can you hear me? Thank you, sir, for the kind introduction. Thank you, chairpersons, and I thank Dr. Sandeep Goyal and the Punjab Neurosciences Society, Dr. Uppal, Dr. Gagandeep for having me talk here. So my topic is very interesting because it deals with a lot of practical issues which are always debated: when to start drugs, when to stop drug, how long to give drugs, and how to choose the anti-epileptics among, as said, there are so many of them available today. So the only challenge is these are all very controversial topics and they need a lot of time. I'll try to concise them into these 20 minutes and let's see if any other questions we can take later. I'll skip all the videos. So when do we start? Two important questions need to be answered to this: whether it is an epileptic seizure. That is very important, and you had enough today differentiation between epilepsies and mimics, so we don't need to go into details. So that is the first question to be answered, because there are implications of either starting anti-epileptic drugs in non-epileptic events and even not starting drugs in epilepsy, of course. And the others are to rule out the seizure mimics. Like syncope seizures, you already gone through them, so my work is easier. The second important question to start anti-epileptic drugs, is it going to recur? So if somebody's had one seizure, I mean, why would you want to give them 3 years or longer treatment if they are not going to have another seizure? And that answers from the new definition of epilepsy which Dr. Gagandeep showed you. So I won't go into detail, but I'll just show you again, because this is all about trying to guess if this patient is going to have another seizure. So if there are 2 seizures over 24 hours, obviously it becomes epilepsy. So we treat epilepsy, not a single seizure. Sometimes we do treat a single seizure. I'll come to that in those scenarios. So you have to prove that patient is going to have a recurrence. If there is no 2 seizures, then as Dr. Gagandeep said, there should be a 60% chance. So if there is a EEG positivity, there is a strong family history, it falls into a syndrome, or if there is a neurological deficit. So if this is all this, then we should be starting anti-epileptic drugs. So, but there are such certain circumstances where the drugs can be withheld. This is important because a lot of the epilepsy patients come from this age group where they are in school going, and though the newer anti-epileptic drugs are trying to be less sedative and less effect on cognition, but it is not true that they're not entirely benign, and people over-treated with anti-epileptic drugs may end up having some effect on cognition in their formative years of life. So there are few scenarios, and actually, I mean, with experience in treating epilepsy, it comes to that you can decide easily. It may not be easy. So I'll just try to go through these points. So if the diagnosis is in doubt, first, when I started 20 years back doing epilepsy, was that therapeutic trials. These days, we don't like giving therapeutic trials. We try it as much as possible by investigations, by home videos, everything to make a positive diagnosis of epilepsy before we start drugs. Second, acute symptomatic seizures may not require, or short term, somebody mentioned them also, and you'll have a full talk coming up. So they may not need long-term treatment. Single seizure, especially in children, as I was saying, the chances of having a second seizure, I'm talking in very broad terms, I can't go into specific studies and all, in young kids is about 30 to 40% of having a second seizure. Whereas in adults, adolescents, it goes up to 60 to 70%. So when the chance is very low of having second seizure, the EEG is normal, imaging is normal, no focal lesion, and these sometimes in this first seizure in these children, we may be able to just guide them properly, may be precautions taken not to get injured, and may not need anti-epileptic therapy at this point of time. There are some specific type of epilepsies like benign Rolandic epilepsy. It's a very common epilepsy in children, which has hemiclonic seizures and benign centrotemporal spikes. But the recurrence rate is so low, and sometimes they may have only 1-2 seizures. Many times pediatricians don't like giving long-term anti-epileptic drugs. But can we have the presentation back? Okay, thanks. So, but it has to be individualized. It has to be, there are risks of not treating. So if you have a scenario when you don't need to start anti-epileptic drugs, it should be a shared decision making. This is coming in big way in Western countries, and we also do that. I do communication in healthcare sessions, and in that basically being sensitive to the patients and the parents' wishes. If the parents are very scared that they don't want to see another seizure, then we have to go with them. So we give them a broader guideline, but decide along with the family and help them make an unbiased decision. So that is about starting the therapy. How long? So when you must have seen in your medicine practice, pediatrics practice, neurology practice, when to start somebody that you will need to take few years of anti-epileptic drugs, the first question is how long do I need to take this? So unfortunately, this is even more complex than when to start anti-epileptic drugs. So the reason is epilepsy is not one thing. It's a huge spectrum. For me, who does only epilepsy, is like tens of diagnoses which have different types of time length required. So you, on one side, you have syndromes like juvenile myoclonic epilepsy, and those epileptic encephalopathies where it's almost like a lifelong treatment, because they may get control, but when you stop, there is a very high chance of recurrence. Then there are those ones which are time bound. So these are the ones which is difficult to say in these patients, and it is very important for us to tell the same thing to our patients, because many times they hear from each other, 3 साल की treatment है, or या 2 साल की treatment है. They will not come back, stop medicine after 3 years in juvenile myoclonic epilepsy, come back with seizure recurrence or sometimes even status epilepticus. So this is where, because there's a long spectrum from few weeks to many decades of treatment, and when should we choose to stop and who should we choose to stop medication and when is a very tough question to answer, but there are guidelines. Thankfully, people have done a lot of research. And so this is the important slide. It is not a exact thing that in an individual patient, but overall. So which are those patients who have a higher chance when we stop? So in patients who don't need few weeks or lifelong, the usual treatment is around at least 2 years of drug therapy. That is very clear. Even Cochrane database reviews have shown that if you stop less than 2 years after a seizure is controlled totally, the chance of recurrence are much higher. And beyond 2 years, whether it is 2 to 3 is the one we actually use. We sometimes use 2 to 3 depending upon the lifestyle, the need of the patient. Patient is getting married, patient is planning to get pregnant. We may choose the shorter one. But usually around 2 to 3 years. Beyond that, it is not been shown to be affecting the future prognosis of the patient. So that is between the patient and doctor. I worked abroad few years, and there people don't even stop for decades, even if they could stop after 3 years, because their laws that you can't drive with epilepsy are so strictly enforced that if you lose your driving license and people travel 50, 60 kilometers, then they don't stop. But those are, we are talking medically, you can stop after 2 to 3 years. So which are the patients I'd be careful about after stopping? Those who have a symptomatic epilepsy, like a focal epilepsy with a lesion, there is a strong family history of epilepsy in the family. People who have age of onset is before 2 years or after 10 years have a higher chance. So these are adolescent and very young patients have a higher chance of recurrence. Young kids again are better, they may have a lesser chance of recurrence. People with IQ less than 70, intellectual impairment, people who have recurrence on tapering before. So people who I tapered after 2 years, they had a recurrence, next time I am wary of stopping after 2 years. Them I prolonged usually, let's say if they are willing, 4 to 5 years. High seizure load, very frequent seizure, not very good response initially. It took a long time on more than one drug to control initially the epilepsy. These people may have a higher chance of recurrence once we stop the anti-epileptic drugs. I already said abnormal EEG, neurological examination. This is a very important, common question I get when we talk about this. Should we do EEG before stopping anti-epileptic drugs? It has two answers. It's for idiopathic generalized epilepsy or genetic epilepsies as we call them, there is a good relationship. If you see generalized spike and waves already going on, the chance that that patient will have a recurrence is high. Whereas in focal epilepsy, the focal epileptic changes don't really correlate very well. We've seen there were some changes, but patient did not have a recurrence. But more important is if during tapering you do a EEG and the spikes go up, that is something in favor of maybe postponing the tapering. And of course, I talked about JMEs and epileptic encephalopathies. These are the patients who actually you can't taper. Oh, I already talked about this slide. So 2 years is the minimum to given in this patient, and 2 to 4 years anywhere you can choose depending upon the circumstances of the patient. If patient is having an active lifestyle, I may not want to taper. Patient is a high-flying executive and they don't want to take one risk of seizure. So if the patient is not ready in their life to take a seizure, there is no harm continuing for few extra years. Another question, how long should we taper? When we decide to take off medications, should we do it over 3 months or 6 months or longer? So research shows that between 6 weeks and 9 months really did make a difference. Personally, what we follow is that if the patient is on one drug, approximately we can taper over 3 months. If the patient is on 2 or 3 drugs, we take it longer. So anywhere between 3 to 6 months is a good time we take from the full therapy to go to zero therapy. I don't know how many of you manage juvenile myoclonic epilepsy. It is very important to talk about it because one of the commonest epilepsies in young people, it is usually misdiagnosed because GTCS is the one which we see. We do not get history of myoclonus. Myoclonus history has to be very, very actively asked for. The reason for that is that if we diagnose JME, one is about the duration of treatment, the other is about specific drugs about these genetic epilepsies. While giving carbamazepine actually may exacerbate seizures. So we have to diagnose this. We have to ask for history of myoclonus in people, young people coming with generalized tonic-clonic seizures. All right. So coming to now the anti-epileptic, this is just a list. I'll be going two lines about each of these drugs. Just the crux, where do we stand with these anti-epileptic drugs in today's time? But before that, what are the factors? Because it's very common. You are being bombarded from the manufacturers by 20 salts and one saying better than the other. It becomes very difficult for us to choose which drug is the best for our patient. But again, thankfully, there are guidelines. So type of seizure is the most important thing, and then there are others. I'll come to that. This is the type of seizure. Epilepsy is the most, I'll just open the full so that I can go through this. So in focal epilepsies, still the data shows that carbamazepine is possibly the most effective drug. No drug has been shown to be more effective in focal or complex partial seizures till now. Oxcarbazepine, being almost a sister drug, is equally as efficacious, but when I get stuck, we have more than 1,000 patients just in the uncontrolled epilepsy clinic. So this is the drug I go to, but there are some issues with this. We'll come to that. Lamotrigine is another good alternative in focal, then lacosamide, and phenytoin is being slightly used less and less because of the hirsutism and other drugs. The add-on drugs are levetiracetam, clobazam, valproate. One point to remember is in focal epilepsy, you can give any drug. So contrast to which I'm going to come to in generalized epilepsies. Any drug will work, some better than the other. That is not the case in idiopathic or genetic generalized epilepsies, especially with myoclonic in absence. Because in this, if we end up giving drugs like phenytoin or carbamazepine and few other drugs, they may actually worsen the epilepsy. In a refractory epilepsy clinic, people are referred for epilepsy surgery to be taken up, and we find that they were juvenile myoclonic epilepsy being treated with carbamazepine for years. They lost years of their life, and we stop it, shift it to valproate, and this epilepsy is gone. So this is very, very important for all of us to know that we have to diagnose these epilepsies and then treat them with proper drugs. So the best drug choice, which is most efficacious, is sodium valproate. Then there are levetiracetam, brivaracetam, I didn't write, or maybe it's an older slide, although I still prefer levetiracetam to brivaracetam, lamotrigine, and then there are lesser uses topiramate and zonisamide. And absence seizures, ethosuximide is now available in India. It is possibly better than valproate, which can also be used in that. So valproate, I put a star because we are using less and less valproate in ladies. I think you have a full talk on pregnancy and ladies, so this is not a good drug in that. I think that will be dealt in that talk. And there are backup drugs like pregabalin, gabapentin, and brivaracetam in place of levetiracetam, where the psychiatric side effects are too much to handle. Other factors are age. So in infants less than 2 years of age, valproate can be very toxic, so we don't like using. I hope my knowledge is right. Please point out the pediatric neurologist if this has changed. In elderly, we like to use drugs which do not have too many enzyme induction or interactions. Because they are on cardiac medicine, they can be on kidney medication. So drugs which are non-interfering like levetiracetam or other drugs which do not get metabolized in the liver are the ones we use in elderly. Young ladies, of course, valproate is going to be dealt with. Phenytoin, because of the hirsutism, we avoid. In cardiac comorbidities, phenytoin is not a good drug, and topiramate has 2 to 5% risk of renal stones. So if you have history in the family of renal stones, I would not want to use topiramate. drug interactions. So drugs which are, I already said, metabolized in liver are the ones which we should be careful in combining with other medications. Urgency of situation is very important. There are only few drugs which can be used on immediate basis, which is like phenytoin, phenobarbital. All these drugs have IV preparations. All drugs don't have IV preparation. So they can be used at the highest dose from the day of the starting. Then there are medium, and drugs like lamotrigine, even though being a good drug, takes 4 to 6 weeks minimum to get on to the dose. So if you're having patient who comes with 2 to 3 seizures and you want to start, lamotrigine is not the drug to start. Even carbamazepine should be ideally given over 10 to 15 days coming up to the dose for the metabolic reasons. Affordability is obviously there in our country, and I already talked about the root of these things. Dosing frequency, the only important point is that there was a study, I think Dr. Gagandeep also did a study on this, is that some drugs are TDS, some BD, some OD. So OD is not a problem. BD also was not a problem because people were taking morning and evening. Drugs like carbamazepine, which had to be taken thrice a day, people used to forget the day dose because in school, at work. So we always like to give a longer release preparation of these drugs so that we make it at least to BD, if not OD. That is the point in this slide. I think this is not required. So if I may take a minute, just a minute, and then I just go through the important points of these drugs, only the ones which I have not already said. I already said currently most effective for generalized, preferred for men, first choice, and that is it. Most effective in focal, one of the cheapest drugs today, but there is enzyme induction. Do not combine with other drugs which are enzyme inducing. Oxcarbazepine, very similar, so people who can afford, this is a lesser interacting drug, so you can use oxcarbazepine. Phenytoin use is decreasing mainly because of the lot of side effects and non-linear kinetics. We can talk about it if anyone wants to use. Levetiracetam is come as a wonder drug in the last 2 decades. You know, it's the biggest point if I have to say about levetiracetam is it neither gets metabolized in the liver, doesn't affect other drugs' metabolism. Probably the only inert drug out of the commonly used drug. Even brivaracetam, which has been very aggressively marketed, has a hepatic induction and can have a interaction with the drug. So levetiracetam scores over brivaracetam also in that thing. I already said the point about brivaracetam. Lamotrigine, probably the lesser sedating drug of all of these, but takes a long time and has a highest risk of skin rash, more than carbamazepine also. You have to be careful. We have to guide all the patients who we start on carbamazepine or lamotrigine that there may be a skin rash. Clobazam works fine, broad spectrum. It's like in catamenial epilepsies, you give, it starts acting in few hours, and it really doesn't interact too much. So that is why it is go-to drug in urgent situations, like any benzodiazepine. Topiramate, I already said, there is a problem with renal stones. Perampanel, you must be getting. So it is a good drug. It has a different mechanism of action than the routine drugs. So that is why we are using mostly in refractory epilepsy. It is not a first-line drug. It has its own issues. But in refractory epilepsy, this is an add-on drug which has given us some good relief. But as you will know in other talks on drug refractory epilepsy, still, after all these drugs, as sir said, we have so many drugs, we still have about 30% patients who we can't control on these drugs. I think I will stop here. This is just a video of my clones. I am not going to show video. You already had a lot of this thing. Thank you very much. If there is any questions now, we can take up or later. Sorry to have hurried you.
Excellent talk, sir. Excellent talk, sir. Just a word on like carbamazepine being an excellent drug other than the TID dosing. A word on eslicarbazepine. How is it in comparison to carbamazepine? It being an OD dosed drug.
Yeah, good question. You know, it didn't become very popular because we already had oxcarbazepine. So same family, we already had 2 drugs. The eslicarbazepine is a little more expensive. You know, working in a public setting in PGI, we are always thinking, but it is now more studies are coming. And there is an advantage over the OD dosing, and also advantage that it may be almost as efficacious as carbamazepine, may have to pay more. There is one study which has shown some recent study towards a neuroprotective effect. although levetiracetam also showed we really don't have any drug in any neurological disorders which is significant neuroprotective. So that is one point in favor of eslicarbazepine. I personally don't have too much of experience in that because we've been using mostly oxcarb and carbamazepine. But that is a drug to consider.
Thank you, sir. Any other questions?
Okay, yeah, good question. But let me just check. Dr. Hardeep is there. You're going to talk about. Are you going to deal with the acute symptomatic these agents? So this should not be repetition. So these come under acute symptomatic seizure due to some concussion, or unless it is a big damage where you treat it like epilepsy. But the lot of things you mentioned come under acute symptomatic seizure, which may not need long-term treatment. Dr. Hardeep is going to deal with that in his talk.
Sir, you go ahead.
After Senate 2 study, which
there
came
are
last
always
year,
very many questions on these topics, so I'm happy outside if somebody wants to talk. Have you have any really questions which you need answers to? Yes, sir.
You mentioned levetiracetam being superior to other drugs, but if you see the Senate 2 study, which the primary result of which was that in primary generalized epilepsy and in unclassifiable epilepsy, valproate still scores over levetiracetam. So your comments on that?
I'll come to that. Unclassifiable, I didn't say it is in the end. So as I said, because the drugs for focal epilepsy, in focal epilepsy, all drugs work. In generalized epilepsy, few drugs work. So if there is an unclassified, which many times we may not know whether it is a generalized when the patient comes first or second time, then we use the drugs which we treat for generalized epilepsy because they will also cover and not deteriorate the focal epilepsy. So that point should be clear that if it's unclassified, we use valproate, levetiracetam. So now coming to your standard thing, of course, I said that I was hurrying. As far as efficacy goes in generalized epilepsies, no drug has overtaken sodium valproate. The problem is with sodium valproate, it is a highly toxic drug in pregnancy and lot of hormonal effects, even in non-pregnant women. So the use is coming less and less in young women where juvenile myoclonic epilepsy and other generalized epilepsies are very common. So what do? So first we try that we use drugs like levetiracetam. That is our first line drug in women with epilepsy. Men is different. And then if it doesn't get controlled, there are resistant JMEs also. Then we give a trial and make sure that they don't get pregnant on that. Rarely it may happen that people do get pregnant on this, and there is a lot of debate going on. There is the American College of Gynecologists which have blacklisted valproate to be given to any women who are, I think, who's going to deal with that? You're going to talking about that, right? So that I will not go into that. So in women, levetiracetam. In men, of course, you're right, valproate is the most effective. So I will talk about it. Yeah.
I think we'll end there, Dr. Rod. We can take other questions over tea, sir.
Yeah, sure.
Thank you so much.
Thank you very much.
Thanks a lot, sir. Can you stay for the facilitation, sir? I request the chairperson to facilitate Dr. Parampreet for such a nice lecture. And also request Dr. Vineet Mahajan to honor the chairpersons with pot of plants. So we have the next session by Dr. Swapan Gupta on drug-resistant epilepsy. And we have the honor of welcoming our chairpersons, Bandana and Kawaljit kindly escort our honored chairpersons, Dr. Gurdev Chaudhary, Colonel Ahmed Sareen, Dr. Dinesh Dada, and Dr. Damanjit. I request the chairpersons to introduce to the audience the speaker for today, this lecture. This is the 6th lecture we have for today in Epilepsy Masterclass.
Do we wait for tea? Because I think many people have gone for tea. Should we wait for 5 minutes? I think so. Because, but people have moved out if you see the hall. Okay. Okay. As the chairpersons decide.
Dr. Swapan Gupta will be talking on a not very uncommon topic, drug resistance epilepsy. We know 1 in 3 will have that. He's a ILAV VIR EPA certified in basic and advanced ECG.
EEG. EEG.
EEG, okay. And he's an associate professor and in charge in comprehensive epilepsy care program and epilepsy surgery department of neurology GB Pant Hospital, New Delhi. And his areas of specialization are neurology, epilepsy, and EEG. He has got more than 500 medical trained. He has trained more than 500 medical personnel, and he has got so many fellowships and awards to his name. I welcome you, sir, for your talk.
Thank you, chairpersons, and thank you, Dr. Sandeep Goel, for giving me this opportunity. I take it from where Dr. Param left that till you use all the medicines, still 30% of the patients will be drug refractory. So over these many years, so many medications have been devised, but still anti-seizure medications will be effective in around 1/3 of the patients. And as a pediatrician, as a physician, or a neurologist, you will be encountering these patients who, even if you give whatever number of medications, the patient will be drug resistant. Now, my job is to tell you what to do in such cases, because these patients are difficult ones. They're not going to leave you. And if you just leave them out, they might cause bad name to a doctor. So we must know how to deal with drug-resistant epilepsy. So as we have already seen, number one thing, if you encounter a patient who has drug-resistant epilepsy, you should rule out pseudo-resistance. What is pseudo-resistance? Pseudo-resistance is the patient does not have resistance to anti-seizure medications. It's the wrong diagnosis, epilepsy versus non-epileptic. It's the wrong drug. It's the wrong dose, compliance issues, and comorbidities, which is not allowing the patient to be seizure-free. And we wrongly label them as resistant epilepsy. So first thing, when a patient presents to you with drug resistance, please check all these factors, and if there is one, you have to rule them out. Then, what is real or true drug-resistant epilepsy? ILE gives the definition as failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drugs to achieve sustained seizure freedom for a sufficient long period of time. Minded, two tolerated and appropriately chosen. So it should be appropriate to the type of epilepsy and to the maximum possible dose used. Why drug-resistant epilepsy is limited to 2 drugs? Why not 3 drugs, 4 drugs, 5 drugs? Why you should label a patient as resistant epilepsy and think of doing something more than drugs beyond 2? The reason is this study, if you see this graph, these are the number of drugs which have been tried, these are the number of patients, and you see the blue graph, which is drug responsiveness. So if there are 2 drugs, still 11% will be responsive, but as you increase the number of drugs, it's coming less than 5% of the patients will respond to further addition of drugs. That's why this limit of 2 drugs is being chosen. And this prevalence of drug-resistant epilepsy is much more common in focal epilepsies than generalized epilepsies. Why this is important to know is because now we have something else to offer to the patient, which is surgery. Surgery now has been established to be the treatment of choice for these drug-resistant epilepsies. And not just seizure freedom, it also results in psychological and economic benefit to the patient. These 2 trials, the landmark trial done in 2001 by Weeb et al., clearly showed that surgical treatment is better than medical treatment. And this recent trial from India, from the AIMS group, showed again that surgery is much better than medical treatment in patients of drug-resistant epilepsy. So beyond doubt, surgical treatment scores over medical treatment when there is drug-resistant epilepsy. Now the question is, you have a patient who has focal epilepsy, who is now drug-resistant. You have ruled out pseudo-resistance. Now what next? You will do an MRI and see the focal lesion. And one is really fascinated to just jump over and try to take out that lesion. But I would say focal lesion on imaging does not directly imply that it is a seizure focus, which is mostly done at peripheral centers, that patient is drug resistant and MRI is showing some focal lesion, and removing the focal lesion is thought to control epilepsy. It might not be true. Let us see some examples. So this patient presented to us, and see the seizures. This is a child who presented with these episodes. These are seizures. These are hypermotor seizures, we call them. So he's having bizarre movements of the body, some laughing spells, and the seizure is over. And this is the MRI. You see on the right side, there is a frontal lesion in the precentral region. So very clear-cut frontal lobe epilepsy, and there is right frontal lesion. This is the EEG which we got, and you see there are periodic generalized spike sharp wave discharges. Do you expect this in this patient? No. We sent the patient for SSPE and it came out to be positive. So it was an incidental finding. Second case, you see this. This person had these seizures. These were choking and retching episodes, and then he would have vomiting episodes. So it was conforming to insular seizures. And he was drug resistant. See the vomiting. And then we did the MRI, and this is the MRI. You see there is a lesion in the left parietal region, and also there is left mesial temporal sclerosis. Now what will you operate? One or both? So this is the diagnostic dilemma for the surgeons. Now see this. Another patient. So see this girl. So she has behavioral arrest. And then some oral movements. And you see there is salivation from the mouth. So where do you localize these seizures to? So salivation, hypomotor seizures, something around insulo-opercular region. And her MRI was showing left MTS. Will you operate this MTS? The surgeons are sitting. Will you operate? No. Unless the neurologist or the epileptologist tells you that this is the seizure focus, unless you establish that, it's dangerous to operate, because this type of semiology can arise from hippocampus, can arise from insula, can even arise from anterior cingulate cortex. So MRI lesion alone does not mean that it is the seizure focus. And imaging alone approach is not appropriate for epilepsy surgery. So this is the second message which I want to give to this house. Then how do we really go about it? That is my third part, which is approach or pre-surgical workup. Localization of epileptogenic zone is the core aim of pre-surgical workup, which is the job of a trained neurologist or a epileptologist. And like you see, this is a team. So we use different modalities to do that, using clinical, using the imaging, using EEG, functional imaging, and other modalities. Let us understand the neurobiology of focus seizures. Now the current concepts of zones and networks. So you see, like this, there is a mesial temporal lesion. So this is an epileptogenic lesion. And then you have the ictal onset zone, which is seen on the EEG, ictal EEG. And then you have the irritative zone, which is seen on the interictal record. And they may not coincide with each other. And then you have a larger functional deficit zone determined by the functional imaging by the PET or the SPECT. So you see all these are different in size and distribution. And then most important is the epileptogenic zone, which is the minimum cortex required to be removed to achieve seizure freedom. So you see this zone is determined by using different modalities or not just one modality. So do we need all investigations to localize this epileptogenic zone? Let us see one by one how careful evaluation and seizure semiology is important. It is very important and useful tool. Why I say that? Because it is free. You do not need sophisticated investigations. It can be done at a smaller center also. But mind it, it only represents the propagation but may not always represent the initiation part. So see, just to give you the idea how do we do that, just see this video, first video. This is a typical mesial temporal lobe epilepsy, wherein the patient has right hand automatisms, left hand is relatively immobile, and now some dystonic posturing. Vis-a-vis on the right side you see this patient who has again same type of findings but less automatisms, which is neocortical. So these subtle signs helps us to differentiate mesial from neocortical temporal lobe epilepsy. And you see the second patient will have faster generalization while the first patient will not have generalization. You see now he is having generalization. So this was having right-sided calcified lesion while the second patient you see was having this lateral temporal gliosis. Then frontal lobe epilepsy, different manifestations like in the motor cortex. This is the second supplementary motor area where you have dystonic posturing of one side, while in the motor cortex you will have only jerking. So this is how we differentiate. We have to correlate the semiology with the MRI finding. Unless it correlates, there is no point going ahead with the epilepsy surgery. See this patient, this is a premotor lesion where is versive seizure, neck going to the left and then generalization, vis-a-vis this child hypermotor seizure with a calcification in the basifrontal. So this is how we correlate. And occipital lobe seizures, there is a lesion there in the occipital region, lateral occipital, and you see in the inset there is fast blinking of the eyes. And parietal lobe seizures, who usually mimic other types of epilepsy. So this knowledge is very important while we approach the patient for epilepsy surgery. For example, see this lady who has this typical left hand automatism, right hand posturing, earlier turning to the left, which means that is a temporal life seizure. But what you see, there is a posterior parietal calcification on the left hand side, and you see temporal is absolutely normal. So it's a parietal lobe is mostly imitator. And then you have ictal laughter, where you see they come from usually hypothalamic hamartoma. This boy has that, and this guy again who has a posterior temporal. So this knowledge of which sides produce what symptoms is very, very important, and not just the MRI is alone important. That's what my message is. So even sometimes we encounter generalized seizures, but they look like generalized seizures, but they may be focal in origin. And this happens usually with frontal lobe epilepsies and posterior cortex epilepsies. For example, see this patient who has frontal lobe epilepsy, but it will look like as a GTCS. So EEG comes to our rescue, where in such cases we see clear cut that there is asymmetry on the EEG, you see. So it's because the rapid generalization with frontal lobe epilepsies results in looking like a generalized seizure. So this is what. And again, infants and preschool children, my colleague mentioned that it happens, epileptic spasms happens only in children, but that is not true. Epileptic spasms, infantile spasms were renamed as epileptic spasms because they can also occur in older children and even adults. So see this child who has these kind of movements, and you see there is epileptic spasm, but it is more on the left hand side and there is asymmetry, and he has actually temporal lobe epilepsy. So in children, even focal lesions can cause these generalized tonic seizures, which is the point to remember. So generalized seizures does not always means that it is not focal. Then structural imaging, yes, it is very, very important, and high quality 3D T1 coronal T2 flare sequences and harness protocol. You can refer to this article, which clearly beautifully gives the guidelines. And I would like to highlight this example, our example where 1.5 Tesla patient was carrying this MRI, having features of temporal lobe epilepsy, and there was not clear cut. When we did 3 Tesla, see how beautifully it is showing features of mesial temporal sclerosis. So please always focus on good epilepsy protocol, MRI, perpendicular coronal sections to the hippocampus, which are very, very important, and reading by a trained neurologist, trained neuroradiologist is very, very important, who is specializing in epilepsy. Otherwise, you will miss a lot of them. Then EEG or video EEG, yes, you need skilled team and resources, very important in pre-surgical localization, and this is the way we do it. So ictal rhythms and interictal rhythms we see, but they usually help in lateralization more than regionalization. Localization means they can tell the site usually, but localizing a particular area may not be always possible. Usually it is possible in temporal lobe epilepsies. For example, if I show you this rhythm, so you see this rhythm. You see how beautifully it is evolving in these leads, right-sided leads, temporal leads. How beautiful it is. While it will not be so in extratemporal lobe epilepsies like frontal lobe epilepsies. If you see this frontal lobe epilepsy, the rhythm is more diffuse. So temporal lobe seizures have beautiful ictal rhythms. Then video EEG is not without any side effects also. Patient can have frequent seizures, and this is a study wherein they found almost 10% have side effects, including psychiatric injuries, and even status have been reported. Then we always do neuropsychology as a part of routine workup. This is for many purposes, primarily to assess baseline cognitive function, because if the patient lands up with some cognitive issues afterwards and they may blame you that it was not there before. So you have a baseline function to support your case, and then it also tells about the site of cerebral dysfunction. For example, left temporal lobe epilepsy will usually have verbal memory impairment, while right side will have visual memory impairment, and but though it is not 100% sacrosanct. So three things: one is semiology, MRI, and third is video EEG are the cornerstone of pre-surgical evaluation, which can be done at a moderately okay medium center, also not a very advanced center. So let us see common scenarios which are drug-resistant epilepsy cases and can be managed as a, you can set a epilepsy center easily. So for example, see this lesion, mesial temporal sclerosis or a benign tumor cavernoma, good clinical correlation with a good MRI and concordant only interictal EEG with a neuropsychology testing is enough to proceed for surgery. You may not always require a ictal EEG also if it is concordant. But I would like to give you a caution. There are some syndromes like burnt out hippocampus syndrome, wherein you have full gliosis and the clinical and the ictal on the interictal findings will be concording to the opposite side. And this is called as burnt out hippocampus syndrome because the seizure spreads very rapidly to the other side. Then coming to the extratemporal lobe epilepsy, if you have a lesion not in the temporal but extratemporally, even then only clinical MRI and interictal EEG or ictal EEG should suffice. Why additional modalities? When there is discordant data, when the MRI is negative, multiple lesions or eloquent lesions. See, for example, this was a girl with drug-resistant epilepsy frontal lobe. We did MRI normal, we did PET, shows hypometabolism, and when we looked at the MRI clearly, see this very tiny focus of calcification operated, now seizure free for last 3 years. Again, this patient, again, normal MRI, we did PET, hypometabolism, and see this small atrophy. This was FCD, and patient operated seizure free for 3 years. And this SPECT, where this shows hyperperfusion, can help us to localize the site. Not required in every case, but in selected cases. This is diffusion tensor imaging, which we map the fibers. Say this lesion, cystic lesion, the surgeon wants to know whether he wants to approach from this side or this side. The fibers are pushed this side, so he approached from this side, preserving the visual fibers. So that is important. fMRI, like in this case, lesion was in Wernicke's area, and we showed that the language has been shifted to the other side. The surgeon could safely operate this region without hampering the comprehension. Intracranial monitoring in selected cases, again, wherein put in electrodes into the skull, done only in minority of the cases at advanced centers, in very few cases. Newer modalities on the horizon, high density surface EEG, MEG, EEG, fMRI are done at advanced centers. So now the consensus has been moving towards, if you have a discrete lesion, please go for early pre-surgical workup, because anyways we know these patients are going to be drug resistant, and more time you take, the difficult epilepsy, it becomes to control. Workup in children, children are different. They have non-localizing generalized semiologies. The etiologies are different, and even the cognitive and developmental improvement happen if you do early surgery. So identifying the right candidate is very important. When you should not do surgery, you should also know when there is clear evidence of bilateral onset, severe psychiatric or medical comorbidity, progressive CNS disease, and primary generalized epilepsy. While these are the common syndromes where we do surgeries, including the hemispherical syndromes and the discrete lesions. So this is the chart which we follow. So if you have a patient of drug-resistant epilepsy, rule out pseudo-resistance, then go for MRI, video EEG, and if they are positive, go for surgery. If there is discordance, go for advanced investigations like SPECT, PET, MEG. Positive, go for surgery. If negative, then consider palliative surgeries. Setting up an epilepsy surgery program, you need a dedicated team, resources, and it's time-consuming, laborious, but it is doable. And communication, finally, with the patient and the family is very important. They should have realistic expectations, and they should understand the complications, that the issues of drug withdrawal should be addressed. So summarizing, epilepsy surgery can provide the best outcomes when the patient is drug resistant, and it is doable at even medium centers. Level 1 can be done. Only minority of patients require advanced testing. Depends on appropriate patient selection by a skilled team. and number of pre-surgical evaluations. Not all are required in each case. It depends on case-to-case basis. Thank you.
I would like to ask, is there any role of vagal stimulation? Are we using that, or diets, any diets?
So these are palliative options which we employ when we cannot do resective surgeries, when we cannot do epilepsy surgeries. Epilepsy surgeries include lesionectomies or removal of the focus. When we cannot do them, then these options come into play. Yes, ketogenic diet, there are some syndromes like GLUT1 deficiency. It has absolute role. Epileptic encephalopathies, where surgery is not an option. It has a good role. But these are the cases where the lesion has to be, is a focal lesion which can be resected. In those cases, epilepsy surgery should be the choice of treatment. That is the message.
Any questions from the house?
Just a quick comment. We know that mostly there are physicians and pediatricians here, and you may not be getting too many resistant epilepsy. This talk is, we all need to be aware of, because the difference between epilepsy, as Swapan said, epilepsy surgery in patients who are resistant to the tune of success rate of 70 to 80% in stopping seizures, versus your patients who you can give any drugs, as I said in my talk, and still they'll be more than 2 drugs, only 5% chance of getting seizure free. So you realize the difference between 5% chance and people who can get surgery, 80% chance of becoming seizure free. If we all know this, we can at least try to be aware about the patients who are not controlled, especially with complex partial or focal with impaired awareness, as we call them now, seizures, and they have specific lesions in the MRI. These may be good candidates. So we can refer them to centers, to neurology centers with epilepsy expertise, or those who have a surgical program. If we do this, we'll be helping our patients immensely who are not controlled on medication.
Yeah, so the key message is epilepsy surgery has now become a very specialized and advanced field, and it is easily now done at many centers without risk, and the benefit risk ratio is much high.
All patients are not candidates, but even half of them, which means there are more than 10 to 20 lakh people in our country who need epilepsy surgery, and the surgeries being done is only to the 2,000 to 3,000 maximum in the whole country. You can see this is the epilepsy surgery is a treatment with probably the biggest treatment gap in the country.
Thank you, sir.
Thanks a lot, sir. May I request the chairperson to give the memento and the gift to our honored speaker. And may I request Dr. Vineet and Dr. Atul Tarun Agarwal to facilitate our chairpersons also. I just want to welcome Colonel Amay Sareen. I think it's his first meeting in Jalandhar today. He has few days back joined as HOD at Military Hospital Jalandhar. He happened to be the HOD of R&R Delhi earlier. We welcome you, sir. So next topic is just continuation of the discussion you had on epilepsy surgery by Dr. Mala Bhaskar Rao. So may I request Bandana and Kawaljit to escort the chairperson on the dais, please. Yeah. So nice, sir. So may I request Dr. Sakil Upal, Dr. Anmol Rai, and Dr. Naveen Chitkara to be on the dais, please. So may I request the chairperson to introduce the honored speaker to the audience, please?
Good evening, everybody. I welcome Professor Mala Bhaskar Rao. I think name is only enough. He is ex-HOD of NIMHANS Bangalore and one of the great epilepsy surgeon of our country. I welcome him to give a talk on it.
Thank you. Good evening to all of you. First of all, I'm thankful to Dr. Gagandeep, Dr. Uppal, Dr. Sandeep, Dr. Naveen, and entire organizing committee of this CME. I wish that through your efforts, hopefully hundreds and thousands of people with epilepsy will benefit in Jalandhar and Punjab. So during this presentation, I'll give you some idea about epilepsy surgery. I have divided my presentation into these three areas. One is give you some historical perspective and to tell you what is happening at present and what are the likely developments in the near future. So 160 years ago, this National Hospital for the Paralyzed and Epileptics was founded in London. The hospital management appointed some doctors and they gave them the free hand to come out with their ideas and then help people with epilepsy. So organized epilepsy care started after starting this hospital. And these doctors at the National Hospital, they made monumental contributions. Hewlings Jackson, he is the one who defined what is epilepsy, and epilepsy comes from cerebral cortex. Focal epilepsy has got focal origin and usually can have underlying focal lesion substrate. And he suggested that remove that lesion to cure the epilepsy. And his colleagues, Govers, who has done extraordinary work in clinical epileptology, and David Ferrier, who has done cortical stimulation, electrical stimulation in primates, in monkeys and then other animals. And of course, they convinced a young colleague, surgical colleague, Sir Victor Horsley, to do epilepsy surgery. Victor Horsley was just beginning his career, young man, and they convinced him to do epilepsy surgery. And all this happened nearly 130 years ago. So the International League Against Epilepsy was formed in the year 1909, okay, 112 years ago. By that time, by year 1909, epilepsy surgery was already in practice. But imagine how much progress world would have gone through, but for many interruptions. Of course, they had a lot of infections. They had a lot of complications. You know, Victor Horsley used it to identify seizures coming from the motor cortex and then resect the motor cortex. So people got cured of epilepsy, but all of them became paralyzed. They developed hemiplegia. So then, because of risk complications, and also because of the First World War, the epilepsy surgery went into disuse. Nobody was using worldwide. But there was one advantage with the First World War. Lot of military personnel with head injuries, post-traumatic epilepsy. So a lot of people studied how trauma, how head injury causes epilepsy, post-traumatic epilepsy. Lot of work has been done. And one young man learned about the post-traumatic epilepsy, how the scar forms, how is the vascularity of the scar, how scar will cause epilepsy, all those things he learned, and he started taking care of people with post-traumatic epilepsy. Actually, this is the this is the world's first temporal lobectomy. It's a soldier who had head injury, operated 3 times. The third time, a scar in the temporal lobe was removed. So this is the world's first temporal lobectomy done by Wilder Penfield. And subsequently, he started the famous Montreal Neurological Institute and started operating on these people. Of course, he used the available investigations those times. One is pneumoencephalography and second one is cerebral angiogram. So Penfield used it to do craniotomy, look for lesion, and then if he finds a lesion, he will remove. If brain is normal, he will just come out. That was so his surgery is lesion based, structural anatomical based. And later in United States, this Gibbs and Bailey, they started doing epilepsy surgery, temporal lobe surgery, based on EEG findings. That to preoperative EEG, they used it to diagnose temporal lobe epilepsy. And they didn't depend on lesions, on angiography and then pneumoencephalography. So they brought this like two sides of the coin. Penfield, structural, lesional based surgery, and Gibbs and Bailey is functional, like EEG based surgery. And then later, Penfield went through many failed cases in his series. And thanks to his neurological colleague Herbert Jasper, they analyzed all their failures, why they are failing patients. And then they realized that they were removing only the lateral neocortex. They are not removing the mesial structures. So they realized the importance of amygdala, importance of hippocampus, importance of parahippocampal gyrus. And then started, of course, those days the names are known. Papal circuit was described. But what exactly the function of amygdala, what exactly the function of hippocampus, one is not sure in 1930s and 40s. So, and also there was a great concern if these structures are removed, whether people's behavior will change, whether they'll forget, they'll become amnesic. So that's why very conservative surgical procedures were done, and that too Penfield used it to do all surgeries under local anesthesia, used it to stimulate and then see whether stimulation is causing epilepsy or stimulation is eliciting function. If it is causing epilepsy, resect. If it is eliciting function, leave it. That was the strategy followed. Of course, by 1950s, things were fairly established well. So taking advantage of that, this Murray Faulkner in London Maudsley Hospital and King's College Hospital, he started doing en-bloc resection. See, Penfield operated all his patients under local anesthesia. They're Canadians, very disciplined. And Murray Faulkner operated in a psychiatry hospital. So the psychiatry hospitals had associated psychiatric problems, behavioral issues, and he could not do awake craniotomy and stimulation studies. So he operated all his patients under general anesthesia. Taking advantage of general anesthesia, he has done en-bloc removals. And then his colleagues from neuropathology department, they were able to identify the changes in the hippocampus. In the previous talk, Dr. Gupta's talk, you heard about mesial temporal sclerosis. That word actually is coined by Murray Faulkner at Maudsley and King's College Hospital. They suggest, actually many neurosurgeons, Shikil must be knowing this question mark incision which you see on many patients. This is all Murray Faulkner's description. And like you, in one of the meetings, one young Brazilian neurosurgeon attended. His name is Niemeyer, and that time the discussion went on in late 50s that it's the hippocampus which is causing epilepsy, which is the amygdala which is causing epilepsy. And then he thought, then why to remove a lot of brain? He said, why don't you just remove the hippocampus and amygdala? So in 1958, he came with this concept of selective amygdalohippocampectomy. You know that the founders of Neurological Society of India, Professor Jacob Chandy, Professor Ramamurthy, they were all trained soon after our independence. They went to UK, they went to US, they went to Montreal, they were trained by Penfield. And then when neurosurgery started in India in 1951, epilepsy surgery also started. They have done a lot of work in CMC, Vellore, and then Madras General Hospital in Madras in 50s and 60s. Of course, late 60s and early 70s, again, the surgery was not performed worldwide for many reasons. There are some countries like Japan and other countries, there is a public protest against any type of functional surgery, saying that it's altering human behavior. And of course, there was no proper indications. The surgical techniques were not documented. Post-op follow-up was not done properly. So this is the statement of Theodore Rasmussen, that the wrong surgeons operating upon wrong patients. That's how epilepsy surgery fell into disrepute in 70s. And of course, another very important factor is these drugs became available. Phenytoin and carbamazepine, they are available. So people thought that they can manage this epilepsy with these drugs. From 1950s onwards, NASA was doing research. Actually, when chimpanzees were sent to space, they wanted to monitor how their heart is beating, how their brain is functioning. So, telemetry, easy telemetry started by NASA space program along with UCLA in Los Angeles, and which became available for civilian use. You must have heard that video easy telemetry in previous talk, and then you must be aware of this, all these technologies. So this came from US Defense Space Research, this simultaneous. So when EEG is being done, initially they used to take photograph, then they moved to cinematography, and then finally to video EEG. So there is a simultaneous second by second correlation between what is the behavioral change and what is the electrical change in the brain. Of course, you know the way the monumental contributions of imaging. Initially in late 70s it is the CT scan, and then early 80s onwards it's the MRI. So we started understanding the surgically remediable lesional epilepsy syndromes. That means you see here, this is an autopsy specimen, normal hippocampus. Look at this size, shape, and here it is small sclerosed. Normal architecture. Here it's a distorted architecture. This is how pneumoencephalography used to find out. You see the size of the temporal horn, and this side temporal horn became big because of the atrophy of the hippocampus. Of course, now this condition can be so easily can be identified with high quality imaging. Normal size and shape of the hippocampus, normal architecture, normal temporal horn, and normal size of the hippocampus. Here you can make out small, distorted, loss of neurons in specific areas, dilated temporal horn, and small hippocampus. Of course, one may think that if it is so easy to identify with MRI, why don't you do MRI for all epilepsy patients, and then when you find the hippocampal sclerosis, take them to the operating room. But unfortunately, we cannot depend on just one finding to decide about surgical indications. It's a multi-modality imaging, clinical, electrical imaging, and cognitive functions. All things should point out to concordance. And like mesial temporal sclerosis, other surgically remediable lesional epilepsy syndromes also were identified. Of course, in parallel, even the surgical techniques also started getting better. The original Niemeyer's technique of 1950s again became popular with work of Ghazi Asargil. He used microscope to do the hippocampal resection. All this is happening in all industrialized countries, making epilepsy surgery heavily technology intensive and technology dependent. Fortunately, in India, the national institutions have taken a lead. So I happened to start the first epilepsy surgery at Sri Chitra Tirunal Institute in Trivandrum in March 1995, and over the last 27 years, I have performed more than 1,000 epilepsy surgeries, and India across 50 different centers, more than 10,000 epilepsy surgeries were performed, and the numbers are rising. That's really good news. And the quality, the outcome of epilepsy surgery done across all these centers is at par with any other center, established center in the world. Like you take US, Europe, or any country, the outcome of Indian epilepsy surgery is at par with the established these centers. And for a fraction of the cost, when we present this data outside, this is in $1,000 US, but same surgery in US will cost about $100,000. So that is the difference. So if you are interested in initiating epilepsy surgery, maybe this is the best approach. So all these 50-60 centers evolved in the same way. Here, the identification of the candidates is very easy. It's a non-invasive evaluation, less expensive, standard evaluation, and the surgery is standard, and outcome is good. So you start here, very easy to identify, outcomes are excellent. And as you move this side, the workup becomes very difficult, and the outcomes are not good. So either with experience, you can take up more and more difficult cases, or you refer them to established centers where these things are taken up in a regular way. So this is how concordance. There are two very important concepts. One is concordance. See, this young girl, she's an engineer. When you look at her, this right hand has gone into dystonic posturing. So the tone is controlled by the basal ganglia, and there's a head turn to the left side. So when you study the entire seizure, you know that seizure is starting from the left hemisphere, left temporal lobe, left mesial temporal lobe, and it is moving. Seizure is propagating from amygdala to globus pallidus. Amygdala is connected to globus pallidus directly, and from globus pallidus it is going to the basal ganglia. So as the seizure is progressing from one anatomical structure to the another anatomical structure, so behavior changes. All the semiology, the seizure behavior, all the neurologists will be able to look at the seizure propagation and will be able to identify from where it is likely to start and then propagating. So this is a left hemispherical mesial temporal seizure. You look at the left hippocampus. This is the normal right hippocampus. You look at the left hippocampus, and both interictal and ictal EEG. See, the EEG also, one is color coded. Okay, these are all right side and these are all left side, and also they are all like close to midline temporal channels. So this all the odd numbers 1, 3, 5, they're all left side. All the even numbers on the right side. So if you are interested, you can discuss with neurologist, and then you can also learn about this EEG. Imaging is easy. So clinically, left hemispherical, left temporal seizure, left hippocampal. You see, the hippocampus is small and white. So it is white because there is a gliosis, and small because neurons are dead. So with every passing seizures, the size will shrink. So there is a clinical, imaging, and electrical concordance. So this is the concordance is very important. Only people with concordance are the surgical candidates. And there is another concept called redundancy. So in my hospital, or maybe in AIMS Delhi, so many gadgets are there to evaluate. So you should not be using all the gadgets on all the patients. So you should.
High risk of the seizures, bacterial pneumococcus carry high risk, parasitic neurocystic cirrhosis, in fungal opportunistic infection, in this mycosis or cryptococcosis, they carry high risk. Mycobacterial, we all know tuberculosis. Mechanism of seizure may include virus-induced neuronal cell death and inflammatory response, and direct effect of bacterial toxin and purulent exudate, leading to the cortical inflammation and resulting in seizures. This is the slide showing the various risk factors. As you can see, more depressed level of the consciousness, cortical lesions, herpes simplex 1 and pneumococcus, they carry the high risk of the seizures in case of encephalitis and bacterial meningitis. Prophylactic anti-seizure medicines are not indicated. We may give anti-seizure medicines after seizure occurrence, and that too for the short duration. Alcohol withdrawal state. Alcohol withdrawal seizures are suspected when the seizure occur within 6 to 48 hours after the last drink in chronic alcoholic. Seizures are usually of GTCS, and these seizures are associated with the typical symptoms of withdrawal such as tremor, sweating and tachycardia. 50% of cases of alcohol withdrawal seizure, they present with repeated seizures. 5% of cases may progress to status epilepticus. Occurrence of seizure is a strong risk factor of progression of the state to the severe withdrawal state. And mechanism is this changes in the NMDA and GABA receptor signaling that develops in the chronic alcoholic, leading to the hyperexcitable brain tissue. This we have already discussed. The seizure occurring within 48 hours of the last alcohol drink, they should be taken as the acute symptomatic seizure that are associated with the other symptoms of alcohol withdrawal, autonomic symptoms, psychiatric symptoms, disinhibition, paranoia. And if seizure occur beyond 48 hours, the secondary search for unprovoked seizure should be made as we do investigations for the unprovoked seizures. Management of seizures in this alcohol withdrawal seizures. In alcohol withdrawal state, we routinely give benzodiazepines such as diazepam, lorazepam that act both for controlling the other symptoms of alcohol withdrawal also as well as the seizures. So benzodiazepines can be routinely given in this alcohol withdrawal state. Metabolic causes. Electrolyte imbalance can cause changes in the neuronal excitability and seizures. Risk of seizures increases with the severity of electrolyte imbalance. And it is the acuteness of the change that is more important than the absolute electrolyte level. Because certain patients with chronic hyponatremia, maybe the tune of 115, 110, they don't develop seizure. And certain patients, if they get rapid hyponatremia, maybe 7 to 8 milliequivalent, they may develop the seizure. So this is the acuteness of the change that is more important than the absolute level that is important for causing the seizures in case of metabolic causes. This table is showing the proposed cutoff values for various metabolic parameters in case of symptomatic seizures in the causing the metabolic seizures. Glucose less than 36 or more than 450 associated with the ketoacidosis. Sodium less than 115, calcium less than 5, magnesium less than 0.8, urea is more than 100, it might be some printing mistake, something there, and creatinine more than 10. So these are the this proposed cutoff values by the ILE for this acute symptomatic seizures. Management, prophylaxis is not recommended. Correction of the underlying cause lead to the cessation of the seizures, and if seizure occurs, ASMs can be given for the short duration of the period. Immune-mediated seizures, there is very strong association between the acute symptomatic seizures and the immune-mediated forms of encephalitis. We all know there are two groups of immune-mediated syndromes: paraneoplastic syndrome, autoimmune encephalitis syndrome. Paraneoplastic syndrome, if they involve the limbic system such as anti-GAD or anti-MA, anti-TAA, they can have high risk of seizures, but otherwise paraneoplastic syndromes, they have low risk. Autoimmune encephalitis syndrome, NMDA, LGA1, GABA, they have high risk. In paraneoplastic syndrome, antibodies are directed against the intracellular antigens, so the risk of seizures is low. Whereas in autoimmune encephalitis syndromes, the antibodies are directed against neuronal surface antigens and the risk of seizures is quite high. Various antigens, NMDA, GABA A, GABA B, LGA1, subunit of VGKC. Management, prophylaxis again is not recommended. Seizures usually vanish when the encephalitis resolves. If seizures occurs, anti-seizure medicines can be given till the encephalitis lasts. Press, we all know, characterized by seizure, headache, visual disturbances. Seizure occur in 60 to 75% of patients. They may progress to status epilepticus in 5 to 15% of patients. Anti-seizure medicine is not indicated. If seizure occur, you may give for the short duration. Eclampsia, that we also know the clinical features of eclampsia, seizures with the other features of pre-eclampsia. Half of seizure occur in antepartum period. Here again, prophylaxis not indicated. If seizure occur, we can give ASM. Here magnesium sulfate is given, and that too for the short duration only. Drugs that are implicated in the acute symptomatic seizures: antidepressant, amitriptyline is quite notorious. In antipsychotic, clozapine, tramadol-induced seizures we see in our routinely in our OPD. Antibiotics, 4th generation spalasporins and ciprofloxacin, we all know. Benzodiazepine barbiturate withdrawal can lead to medication withdrawal seizure, and certain recreational drugs also, cocaine and amphetamines, that can lead to seizures. So this slide is summarizing all the causes that I have enumerated, the various risk of the seizures with the various diseases and various risk factors. We can see the risk is quite high in case of hemorrhagic stroke, CVT, viral encephalitis, autoimmune encephalitis, press, and the more the lesions are toward cortex, larger are the lesion, or there is secondary hemorrhagic transformation, or certain organisms such as herpes 1 or pneumococcus or some autoimmune antibodies, they carry the high risk. So we have to be cautious in these categories about this seizures. So after studying all this we have evaluated when patient has come to us with the seizure, and we have evaluated whether this is acute symptomatic seizure or whether it is some unprovoked seizure. We come to know it is a condition that can lead to acute symptomatic seizure. Some hyponatremia has come, stroke has come, TBI has come. So whether in those conditions, now the seizure has not occurred, before the seizure occurring, in all these conditions, whether to give prophylaxis or not. So this study was published by Yeram in Journal of Intensive Care. They did extensive review, and from all the ASA guidelines, CHA guidelines and others also, and they concluded that definitive prophylaxis before the seizure occurrence. Prophylaxis is indicated only in case of severe traumatic brain injury, and prophylaxis that too only for 7 days. Severe traumatic brain injury, that we have already seen. Probable prophylaxis, they propose for unsecured aneurysm in subarachnoid hemorrhage, where seizure can lead to further bleeding, or elevated intracranial pressure. So these three conditions they propose, we can give the prophylactic anti-epileptic drugs. But in rest of the conditions, none of the conditions they propose the prophylactic anti-epileptic drugs. No seizure has occurred, so we have to give medicine. We have to give anti-seizure medicine. So what should be the duration of that course or duration of that anti-seizure medicines? So this was also a review article that was published by Nisali Gunawardene in Current Treatment Opinions of Neurology. She proposed short-term treatment with anti-seizure medicines is appropriate in the most of the conditions. Long-term treatment may be considered in patients with persistent EEG abnormality or in those patients who has developed the structural changes on imaging. Structural changes, some hemorrhagic stroke has occurred, traumatic brain injury has occurred, that has led to the secondary structural changes, and that may lead to secondary epileptogenesis. In those cases, last slide, sir, I'm finishing. In those cases, long-term anti-seizure medicines are indicated. Long-term, but how long? That also, in this area, for how long? There are no class 1 studies, and not much of this work has been done in this area. But here it was study that was Sonne McLaughlin that published their outline, their management, their outline of current practice, and they made some suggestions. In case of stroke, for 1 year, severe head injury for 2 years, meningoencephalitis. If meningoencephalitis has completely resolved and MRI is normal for 3 months, meningoencephalitis with residual deficit or MRI changes are there. For 2 years, parasitic granuloma, if it has completely resolved, with normal MRI for 3 months, and parasitic granuloma if persisted or calcified for 2 years. Cerebral abscess or tuberculoma also for 2 years. So these were the recommendations they made on their practice in Europe. But still, there is large dilemma that how long to treat. Some people recommend for 3 months, some for 1 year, some for 2 years. So still, lot of work is needed in this area. Head-to-head trials are RCTs are required to make some definitive conclusions in this area. Thank you.
Thank you, sir, for a elaborate talk.
So any questions I would like to answer? Please.
Please give him the mic.
Yeah.
I must congratulate Dr. Hardeep in bringing out where not to give. Because most of the times, practically, we neurosurgeons, out of fear that the patient may throw a seizure, give the anti-epileptic. But even at AIMS, I'm from AIMS, they have changed the scenario. One additional help that we can take is from the CT itself. The dictum is that if you feel that the patient has a seizure, and if he can herniate, in those cases, you give. Even if it's, because the definition of severe head injury traditionally was anything above 6 hours of LOC, we used to label it as severe head injury. But nowadays, practically, if you see, patient may be unconscious for 6 hours, but once you see the CT, it may not be a severe head injury. So in those cases, again, it's not indicated. So even I would recommend in cases with large MCA infarcts, where we are planning a decompressive cranectomy, you must give prophylactically, because before we can conduct decompressive cranectomy, if the patient throws a seizure, then there is a risk of a herniation.
Yes, sir.
So that's a practical, we can make the things easier if we follow this dictum.
Yeah, sir, exactly. I absolutely agree with you. And this person has stated in this, elevated intracranial pressure, that is one of the probable prophylactic indications we can give prophylaxis in that. So that is very well taken, sir. Thank you.
There is an Indian study by, if I can recall, Ramamurthy, I think, and he concluded that of all the cases which we see as clinicians, more than it's around 20 to 25% are acute symptomatic seizures. So that's an Indian study. But keeping in view the logistics we have, the infrastructure for investigations, and the prerogative of the clinician to institute an investigation and to find out the cause, it's a laborious process. I think the cases of acute symptomatic seizure must be many times higher. It should be around 40%. As in an international study is showing 40%.
40%.
So what the message should go home, that we should try everything possible to investigate every case of epilepsy, especially in adults, leave alone pediatric population, and try to find out a cause. And especially metabolic causes can be there, barring hypo and hyperkalemia. They do not cause. And I think any other abnormality, electrolyte abnormality will cause a seizure.
Dr. Hardeep, can we just...
Sir, please.
I fully agree with what you were saying. In fact, that was one comment I wanted to make. Even in pediatrics, that is one indication where we will give prophylactic anti-seizure, that if there is a possibility of herniation, you should be starting anti-seizure drugs. And in that scenario, phenytoin has got the best available evidence. Now people are started using levetiracetam as well. So these are the two drugs that can be used in that scenario. The other comment I would want to make is autoimmune encephalitis. So here sometimes the seizures are very refractory and you have to simultaneously start immunomodulation. That we have seen that it works even better than your anti-seizure drugs. That doesn't mean that you don't have to give anti-seizure drugs, but you have to start it upfront. So you have to start on methylprednisolone with IVIG, and maybe at times we have to do PEGs or maybe rituximab. That goes along with your anti-seizure drugs, because then it gets very difficult to control here. Thank you.
The dilemma remains between levetiracetam and phenytoin. traditionally we are giving loading doses of phenytoin. But
Phenytoin,
our neurologist colleagues, they will not give a loading dose of levetiracetam. So what should be the exact, like from now onwards, what should be the exact?
We always give a loading dose of levetiracetam. I mean, the only thing is that we need to realize that the loading dose of levetiracetam is much more than what we usually give. So it's 30 milligrams per kg, so it comes out to be at least 3.5 grams. But we always give a loading dose.
Thank you, everyone. Please keep the comments short. I think we should be
Wonderful
closing.
talk, wonderful talk.
Okay, sure. She's the senior most person, I think.
No, there are political and economic issues also. Phenytoin drug was invented by United States. Carbamazepine was invented by Europe. So, and phenytoin is available for almost 6-7 decades. It is less expensive, and all the neurosurgeons are familiar for decades of experience. I'm sure newer drugs will be better, but it will take some more time for the data from new drugs to come. Thank you.
Thank you, everyone, for a nice and interactive discussion. And back to the organizers for doing the honors.
Thanks a lot. Big applause for the presentation, sir. Thank you. Can I request the chairpersons to facilitate the honored speaker? Dr. Hardeep, can you come on the dais, please, again? Thank you, sir. Can we have the honor for our chairpersons also? So we have the next lecture from none other than Dr. Sandeep Goyal, who is the organizer of the show. Can we have a clap for Dr. Sandeep Goyal for such a big and enthusiastic effort? He is speaking on status epilepticus, refractory, super refractory, status epilepticus, and NCSC. Can I request Kaval and Pandana to escort the chairperson for this session? Dr. Mohanjit Singh, Dr. Sandeep Janeja, Dr. J.S. Nanua, and Dr. Rajesh Reen, please on the dais. Can I request the chairperson to say a few words about Dr. Sandeep Goyal? But I know that he doesn't definitely need an introduction here. Everybody knows him so well. So a few words from you. Thank you, sir.
At the onset, I would like to congratulate Dr. Sandeep Goyal for organizing this wonderful epilepsy masterclass for us. For the biodata, he doesn't need any
I don't think he
introduction.
remarks us only. He doesn't need any formal introduction, but it is my privilege to introduce him. He did his MBBS from Dhyana Medical College, Dhyana, and MD again from the same institute. Then he did DM Neurology from GB Pant Institute of Postgraduate Medical Science and Education. He has more than 18 years of experience in the field of neurology and has many papers published to his credit. He is currently working as HOD Department of Neurology and Director of NHS Hospital, Jalandhar. So with these words, I'll request the speaker to deliberate on the subject of status epilepticus.
देखो नहीं दिख रहा। Good evening, everybody. Thank you, dear chairpersons. First of all, I thank Dr. Gagandeep to tell me you have to speak definitely on this topic of status epilepticus. Status epilepticus is a medical emergency with high morbidity and mortality, as we know, with an overall annual incidence of around 10 to 41 per 1 lakh population. And in around 50% cases, there is usually no prior history. This distribution usually follows a U-shaped distribution, that is, status epilepticus incidence is more common in the children, and as the age advances, the incidence it's lower in adults, and as the age advances, the incidence increases as the age is increasing. In 1904, it was described by Clark and Prout as a state in which seizures occur so frequently that the coma and exhaustion are continuous between the seizures. In 1940, it was described by Kiner and Wilson as the most severe form of seizures in which the post-convulsive sleep of one attack is cut short by the development of the another. In 1964, ILAE described it as a seizure persists for a sufficient length of time or is repeated frequently enough to produce a fixed and enduring epileptic condition. And in 1993, it was described as more than 30 minutes of either continuous seizure activity or 2 or more sequential seizures without full recovery of consciousness in between them. But now, the definition has actually changed. It is described as T1 and T2. T1 is described as the time at which emergency treatment of status epilepticus has to start, and T2 is the time at which the treatment should be successful in preventing long-term consequences so that there is no damage. It is 5 minutes for generalized seizures and 10 minutes for focal seizures, T1. And T2 is 30 minutes for focal seizures and 60 for generalized seizures and for 60 minutes for focal seizures. So once a patient of status epilepticus has come to you, you are going to see whether it's a premonitory status epilepticus, give benzodiazepine. And if the benzodiazepine is not effective, then it is a benzodiazepine refractory status epilepticus. And then you have to give another medication, second line medications. And if still doesn't respond, that is, you have given one benzodiazepine and one other agent. This is called as refractory status epilepticus. And if the condition persists for more than 24 hours after giving anesthetic agents also, then it is called as super refractory status epilepticus. That is, you have given benzodiazepine, you have given second line agent and anesthetic agent also, and it's still not controlled for more than 24 hours. If still not controlled for more than 7 days, then it is called as prolonged super refractory status epilepticus. And if you don't give anesthetic agent, this is called as prolonged refractory status epilepticus. So, classifying status epilepticus is status epilepticus with motor phenomena and non-convulsive status epilepticus without motor phenomena. So, it is either tonic-clonic for generalized seizures or biclonic or focal motor or tonic or hyperkinetic. In non-convulsive status epilepticus, there is either comatose state or sometimes the aura can be persisting, which can present as non-convulsive status epilepticus. Non-convulsive status epilepticus usually diagnosed by an EEG, which will give you discharges, whether they are more than 2.5 hertz or less than 2.5 hertz. Just to show an example, this is a patient who came with coma, who had previous history of surgery and a VP shunt, and there was no reason to see whether the patient is comatose or not, and the EEG was done, which revealed status is going on, and he was treated with anti-epileptic drugs and he improved. There are two conditions more, that is nausea and fires. There is new onset refractory status epilepticus (NORSE), in which there is no previous history of any insult to the brain or any other acute damage which has come to the brain, but the patient is having status epilepticus. Fires is a condition in which there is a history of fever which is persisting for more than 2 weeks. Epidemiology, as I have told you, it occurs more in the elderly. Etiology, it can be divided as symptomatic or cryptogenic. Symptomatic reasons can be acute, like stroke, intoxication, or any encephalitis. Remote can be post-traumatic, post-encephalitic, or post-stroke. or progressive, in which there's a brain tumor or various other disorders. Or it can be cryptogenic, in which though there's no defined etiology. But practical is two parts, that is common early recognizable causes, and the other is uncommon or rare causes. Common causes are stroke, brain trauma, infections, alcohol or drug-related effects, and low anti-seizure medication in patients. And the uncommon causes are immunological disorders, mitochondrial disorders, infective disorders, genetic or dietary drugs or toxins. So various common causes, the high mortality is in patients with hypoxic brain damage or any anoxia to the brain. So goal of treatment. Goal is definitely the termination of status epilepticus when it is occurring, the management of the precipitating cause, management of complications, and prevention of seizure recurrence. So once a patient has come to you, you have to secure full history, get to know when the patient was last well seen, whether the onset was witnessed, whether the onset was epileptic or a deficit preceded the seizure, whether there was any history of trauma or any comorbidities, or there was any history of pre-existing epilepsy, whether the medication the patient was taking was right or not, or he was missing or not. Then one has to really see whether it's status epilepticus or not. Sometimes cardiovascular conditions can really present as comatose patients, and you can suspect status epilepticus. Once the patient has come to you, you have to stabilize the vitals, do the bedside examination, manage the airway. Look for any hint of overdosing, any organ failure, or any medications of the therapeutic window, or any medications which precipitate the seizures. Imaging is must. MRI is preferred than CT. Do the various lab investigations like LFT, RFT, toxicology screen of urine and serum levels of medication. So once a patient has come to you, within 5 minutes, you have to see the airway, do the ECG monitoring, check the sugar levels, get an IV access. If the sugar is less, you can give thiamine and sugar. And if the time duration is after 5 minutes, after this, then you have to load the patient with various agents like phosphonatoin or valproate or levetiracetam, anyone is good. And if the options are not there, then you can use intranasal midazolam or intramuscular midazolam, or sometimes rectal diazepam. Among the diazepam, various benzodiazepine agents, the diazepam has an onset of action around 3 to 50 minutes, while it is less than 2 to 3 minutes for lorazepam and less than 2 minutes for midazolam. While the duration of action is maximum with lorazepam, that is 1.5, that is up to 12 hours. And for diazepam, it is around 20 minutes because of the redistribution, and it is 1 to 1.5 hours for midazolam. But all these agents are known to cause hypotension and respiratory depression. So diazepam is an age-old used drug. Lorazepam is more effective because it can work for more than 24 hours, and midazolam is also quite effective. After giving the benzodiazepines, you have to use the other agents like phosphonatoin or valproic. Phosphonatoin is used in the dose of 20 mg per kg, and valproate is used in the dose of around 40 mg per kg. And levetiracetam's recommendation is 60 mg per kg now. And if the seizure still continues, you have to use other agents. The various agents that is second line used are phenytoin or phosphonatoin, valproate, levetiracetam, lacosamide. Lacosamide is a drug which is being used since last 4 or 5 years. Phenobarbital is a gold line agent which has been used since last many years as IV formulation, and is said to be more effective than the previous 3 medications. Then there was one ESST trial which evaluated 3 drugs, and there was no difference in the percentage of the patients with seizure cessation among the 3 drug groups, and this small incidence of side effects which were almost equal with all agents. Lacosamide being used, it is said to be effective and really works good, but it is almost the same percentage. Levetiracetam is also new kid of a block. Then few special situations one has to take care, like in COPD and asthma patients, you avoid benzodiazepines. In patients with heart failure and children, you give the infusion slow. And in patients with renal failure, you avoid levetiracetam. In patients with mitochondrial disorders, you avoid valproate. And if the patient has hypotension, then one has to use the various agents very judiciously. So if the patient, these drugs don't work, then it is refractory status epilepticus. And if you have to give various anesthetic agents like midazolam, propofol, pentobarbital, thiamine, and ketamine in the various doses as I have depicted. The poor outcome is in those patients where the duration of seizures, including the time for the first medical attention, is more than 5 hours, and time to control seizures is more than 3.5 hours. Underlying etiology, stroke, anoxic damage, as I've told, and infections really fare bad. older age, and associated medical conditions and any focal neurological signs at the onset are also very bad prognosis factors. So algorithm is very clean and clear that you have to, once you have to give benzodiazepines, then the other agents, 3 agents, or if not working, there's some question mark that you can repeat another second-line agent, or you have to go to this various allosteric agents. So this is just as to show an example, a patient with autoimmune encephalitis who had status epilepticus. So this is a patient. This is a patient who had come to us in emergency with status epilepticus, who had continuous seizures which were persisting. Then after controlling the patient in 24 hours, the EEG was fairly good, and the MRI revealed autoimmune encephalitis. So take-home message is time is brain. There has to be right medication protocol which has to be followed, which has to be kept in your triage. Appropriate doses have to be used so that the status epilepticus can be prevented and treated well. And monitoring of the patients in good EEG settings is must, and one has to define the etiology and so that the seizures don't reoccur. Thank you.
Sandeep, for giving such a nice and talk, and it was very crisp, and you kept the time also.
Yes,
within
I
limits.
had to. So that's why I was running.
I want to ask.
Yes.
When the patient comes and is convulsing, it is a practical difficulty to establish an IV line many times. Have you tried transrectal medication?
So I have not used transrectal medications, but I always advise. The problem is the clinics where the patient, sometimes the patient doesn't reach the emergency. Suppose you have a small clinic, the patient has come to you. Best is intranasal midazolam. That has to be there in your emergency tray. The dosage, yes.
So if IV route is not accessible, suppose we are not able to get a vein, there are 2 ways. One is we give intramuscular midazolam. It might be a little slow, but intramuscular midazolam particularly is pretty fast, but the absorption can be erratic. The other thing is if nothing is possible, then you can give an intraosseous injection. So just like we do a bone marrow, use a bone marrow needle and just inject, it will all go into the blood eventually. So that is one option that can be done.
Sir, another question, the dose of levetiracetam, you gave 30 milligram and he gave 60 milligram.
It's just the new recommendations which are coming up.
So it comes out to be about 3,500 to 4,500.
Less than 4,500 mg.
That the upper limit is about 4,000 milligrams.
Yes. Yes.
Also, I mean, we can't cover everything in this short. So, the rescue therapies are basically used mainly for people who have very frequent seizures at home, not in the hospital. Simply being that we don't have that kind of medication where all the mechanism has failed, as Dr. Goel said. That may not be very effective, but still, if nothing is working, you could, whatever Dr. Gagan said, intramuscular is better than all these. But you can try, but because usually they are for milder form of seizures and at-home therapy, there are being worked inhalational alprazolam, which may be more effective, almost like IV. We don't have them yet; they're still under trial. So these are only the backup where nothing else is available. Mostly used at home. Intranasal, rectal is no more used because intranasal is better and easier to use than rectal.
How do you suspect autoimmune encephalitis in such a patient?
So one has to take some good history, then MRI findings, then CSF, and then you have to get the various autoimmune antibodies in the CSF. They will diagnose.
If there are no more questions, I had.
Thank you.
Thanks a lot, sir. I request the chairpersons to honor Dr. Sandeep Goyal. Can we have the round of applause, please? Can we have the opportunity of honoring our chairpersons also? Dr. Tarun Agarwal and Dr. Mahajan, please. Thanks a lot, sir. Next lecture is by Dr. Salil Uppal. He is speaking on epilepsy and anti-epileptics in fertility and pregnancy. Can I request Bandna and Kawaljit to escort the chairpersons for the event? Dr. Anupma Chopra, Dr. Vibha Chitkara, Dr. Aarti Gupta, and Dr. C.P. Sikka. Can you be in the chair, please, ma'am?
Slides कहाँ से आ गए?
Can I request the chairperson to introduce the speaker to the audience, please?
Good evening, friends. I am happy to see that the hall is still full in spite of 6 lectures already on the floor. But this topic is very, very important. Management of epilepsy in women, particularly in pregnancy, and rather before pregnancy, which drug should be given so that we don't have problems during pregnancy. Reason is that pregnancy itself has got some risk of fetal malformation, but once the patient is on anti-epileptic drugs, the chances of fetal malformation become double. And if the patient is on polytherapy, more than one drug, the chances of fetal malformation becomes 3 times. So this topic is so important, and it has got a lot of carry-home messages, and for that we have got Dr. Uppal on the floor, and I request my co-chairperson for the introduction.
Well, good evening. First of all, I would like to congratulate Dr. Sandeep for organizing such a good conference. And secondly, I'm really lucky to give my presentation in front of my boss, Dr. Gagandeep Singh, and Dr. J.S. Guraya, who is sitting just in front of me. Now, and I was looking for the opportunity so that a gynecologist should be a chairperson. That will be then a easier and also a tough job for me. Anyhow, epilepsy and anti-epileptics in fertility and pregnancy. What do we know till now? We just know sodium valproate, whether to give, whether not to give. We don't go beyond sodium valproate. Sodium valproate is not the only thing which we should be considering in the fertility and in the pregnancy. What other things? Because if we see WWE, that is women with epilepsy in India, if we see about 1/6 of the women are living in India, and also if we see, it is estimated that there are about 2.73 million WW in India, 52% of them are in reproductive age, which is a lot of percentage. What other issues beyond sodium valproate? Menstrual cycle abnormalities due to epilepsy and anti-epileptic drugs, cosmetic side effects, bone health, sexual dysfunction, family planning, then pregnancy, fetal outcomes. Not only pregnancy, what after pregnancy, what before pregnancy, and of course the breastfeeding. If we go to the puberty, that's 17 to 14 years, 7 to 14 years, there is change in type of epilepsy phenotypes. That is, the genetic syndromes may remit or they can arise also. Also, there can be changes in anti-epileptic pharmacokinetics, because we know there are two beautiful hormones, that is estrogen and progesterone. If there is a balance, everything is good. If there is an unbalance, it can, because estrogen is pro-convulsant and progesterone is an anti-convulsant. And estrogen decreases the threshold, progesterone increases the threshold. That is the basic concept of all the things which we deal, whether it is related to the contraceptions, whether it is related to the menstrual cycles. This balance is very important. If we talk about the catamenial seizures, the tendency increases related to the menstrual cycles. And if we see 30 to 50% have epileptic patterns that correspond to menstrual cycle, highest just before and during flow and at the ovulation, because there is relatively, again talking about high estrogen levels and low progesterone levels. Very difficult to control with anti-epileptics at that time. Increasing the doses premenstrually may be beneficial. Then, of course, the cosmetic side effects. Cosmetic side effects we know by phenytoin, hirsutism is there. Then by sodium valproate, hair loss can be there. By sodium valproate, weight gain can be there. Of course, there are other connective tissue disorders which are related to phenobarbitons and phenytoin also. Then, body weight. Weight change is important consideration in anti-epileptics, especially when we are considering about sodium valproate also. We are talking about benzodiazepines also. These can lead to non-compliance to the drugs. This can lead to like self-esteem. Oh, my body weight is increasing. Should I taper my dose myself without consulting a neurologist or consulting a doctor? They do that, and which ultimately leads to seizure. So if we see by valproate, by gabapentin, by carbamazepines, pregabalin, there is a gain in weight. Of course, loss of weight by topiramate, but topiramate, as Dr. Parminder already told, that it can cause renal stones also. So neutral is like levetiracetam or lacosamide. Epilepsy and bone health is very important, because these phenobarbitols and phenytoins are associated with bone loss and fractures. Basically, there is demineralization, especially if using anti-epileptic drugs which induce the hepatic cytochrome P450 enzyme. Basically, there are two types of anti-epileptic drug categorization. One is enzyme-induced and one are the non-enzyme-induced. When these are the enzyme-induced, they can cause this demineralization. And if we see carbamazepine, whenever a female, especially in the old, I will say menopausal female, is on carbamazepine or oxcarbamazepine, we should specially check the calcium levels of the female at that time also, because hypocalcemia, bone loss, fractures, all these things are associated. But lamotrigine is not associated with these bone losses. Now coming to the contraception, I told we are coming towards closely to the fertility level. These were the other effects of the anti-epileptic drugs. So, anti-epileptic drugs and oral contraceptive, they have basically high interaction. So, oral contraceptives, which are metabolized by the liver, they are high protein bound and have low and variable bioavailability. So, what happens? Inducing effect of some anti-epileptics on estradiol and progesterone, that leads to basically oral contraceptive failure. So, as I told, enzyme inducing, which are those? These are the like phenobarbital, phenytoin, carbazepine, oxcarbazepine, topiramate. And basically, what is the mechanism? they induce hepatic cytochrome P450 enzyme system. There is increased clearance of the contraceptive steroid, increase in the level of the sex hormone binding globulins, and there is decrease in the level of freely circulating progesterone. So if a female is on oral contraceptive, what other anti-epileptic drugs other than phenytoin, carbamazepine, non-enzyme inducing, which zonisamide, of course sodium valproate, but again a controversy, reproductive age, reproductive female, she gonna be pregnant, should we start on valproate or not? Later to be discussed. Gabapentin, levetiracetam, pregabalin. So if we do combination of all these oral contraceptive pills, so higher estrogen dose is needed, that is around 50 microgram. But always remember, if a patient is on lamotrigine, if we are giving a combination, these combinations reduces the lamotrigine level by 50%. So higher doses of lamotrigine is needed if there is a combined or use of oral contraceptive pills. Otherwise, what other can be in? The gynecologist know better. Depomedroxyprogesterone acetate, Mirena, barrier methods, and high doses DMPA can be given. So, as I've already discussed about these interactions, now the question comes. A female comes to a gynecologist, a female comes to a neurologist, a female comes to a practitioner. Doc, I'm on an anti-epileptic drugs. Am I fertile? Can I be pregnant? Can I bear everything? So the answers are yes. But on the other side, if we see infertility is present in the females, and if we go by the definition that is given by the woman with epilepsy in year 2014, infertility is the failure to conceive after regular intercourse in a woman who are not using contraception for duration of 1 year for women less than 35 years and 6 months for more than 35 years. But there are other factors also for the infertility. What were the factors? Earlier in USA, allowed forcible sterilization in women with epilepsy. Well, these were the old thinking, old myths. Then in UK, people with epilepsy were not allowed to marry till 1970. Until 1999, epilepsy was ground of annulment of marriage in India also. So these were the things which also lead to the fertility of the woman. Not only the anti-epileptic drugs, but other the most important, if we see social stigma, social taboo. Till now also in India, this social stigma and social taboo of epilepsy is there. So we as a practitioner, we need to explain, we need to eradicate this myth that a female with epilepsy cannot marry, she can bear a child, she can breastfeed also. So this is the job of the neurologist along with the gynecologist. If we see, some female with epilepsy, they choose not to have pregnancy. This also causes one of the infertility thing. I guess my slides are over, the heading is not coming due to change in the Mac, right, probably. And if we see, there is sexual dysfunction also in women with epilepsy. If I be short, there is reduce in sexual desire because of reduction in the androgens. Also, there is reduction in the sexual arousal also. That is basically reduction in the estrogen. And also, sexual dysfunction is also due to comorbid depression of that patient is on long anti-epileptic, she is having comorbid depression also plays a role. If I go by the mechanism, why it happens, there is a hypothalamic pituitary ovarian axis. I'll be very in short in this. Basically, there is an interaction of the neurohormones with gonadotropic hormones. Why I'm showing this? Because temporal lobe epilepsy, the paramoximal discharges also disrupt this hypothalamic pituitary axis, due to which there is decrease of the luteinizing hormone also, which leads to further syndromes like polycystic ovarian syndrome, then hypothalamic hypogonadism, functional hyperprolactinemia, premature menopause. These are the interactions of various anti-epileptic drugs related to the. Now the big question, pregnancy. Drugs generally contraindicate pregnancy. If we go by the FDA approval, there is no class A, no class B, there is class C, class D, and class X. Most of the drugs comes in the class C, and also patient If not taking anti-epileptic during that time, patient thinks I'm being pregnant, I stop anti-epileptic. She will have a seizure. It can cause injury to the patient, it can cause injury to the fetus, it can cause miscarriages, it can cause, due to anti-epileptic, developmental delays can be there. Then, there can be complications of pregnancy and labor due to anti-epileptic drugs. But in general, if we see, there were different registries done, 63.6% seizure frequency and anti-epileptic treatment remains unchanged. Good news, women who have better control of seizures prior to pregnancy usually have few seizures during pregnancy. That means proper compliance to the drug is there, patient is seizure free at least before the pregnancy. The chances of having a seizure again during the pregnancy are very less. Why seizure frequency increases in pregnancy? Because of sleep deprivation, that is, sleep deprivation is one of the trigger for seizures. Then there is alteration of the anti-epileptic drug pharmacokinetics, poor compliance, decreased drug levels, decreased free drug levels, lack of absorption, hyperventilation during labor. These are the reasons. This is the mechanism basically. Total body water increases, extracellular fluid, alter drug distribution is there. Then there is an increase in the hepatic blood flow, increase in the renal clearance. So it depends on whether the patient is, what anti-epileptic drug is there, whether the dose should be increased or not, depending on all the factors related to during the pregnancy. So now coming, pregnancy divided before conception, conception, then delivery, then after and during the labor also. So pre-pregnancy counseling, patient on sodium valproate. Now the question comes, patient on sodium valproate, before conception, you need to counsel the patient. As sir already told that counseling is really necessary, whether to start anti-epileptic drug, whether to change anti-epileptic drug, or whether to stop anti-epileptic drug. So educate the family regarding the anti-epileptic drug side effects, especially sodium valproate. Of course, not only sodium valproate, carbamazepine is also there, phenytoin is also there, because different anti-epileptic drugs have different side effects during congenital malformation can take place. Also, you need to tell about the birth defect to the female before conception, that by this drug, this birth defect is there. And changing an anti-epileptic drug can cause increase of seizures in the patient. After conception, do not change the anti-epileptic drug. Refer for prenatal care. Prescribe vitamin folic acid to the patient. And very important, this slide is really important for especially the gynecologist also, for the practitioners also. We need maternal serum alpha fetoprotein at 15 to 22 weeks of gestation. Level 2 ultrasound, that is a structural one, 16 to 20 weeks of gestation. Aminocentesis at 15 to 20 weeks of pregnancy. Because prenatal testing is important, we can save if there is a congenital malformation, we can counsel the patient and the family related to what further can be done. If we go by now, think there was patient comes, she comes to know at 4 weeks, or she comes to know come at 6 weeks on sodium valproate or carbamazepine or other drugs that she's pregnant. Don't get panic at that time what to do. Just remember that जो neural tube defect होना था अगर है वो तो हो गया या 7 to 8 weeks. These are the different like formations, like central nervous system till 8 weeks, heart till again 8 weeks, arms 9. So these are the all developments which takes place in the child, in the fetus during the course of the pregnancy. So if we see by the risk, otherwise also, if the female is not on anti-epilepsy, she is not having epilepsy, 0.5% is the risk in general population also. 1 to 2% is in the sodium valproate and 1% risk in carbamazepine. So if we see overall the difference, there is not much difference. Of course, I will not say ki if the patient is on sodium valproate or other things, just ignore the risk. We have to really investigate, prenatal investigation is important. So if we go by the defects, cardiac defects are by the phenytoin, phenobarbital, valproic acid, orofacial clefting by phenytoin, phenobarbital, valproic acid, gastrourinary by phenytoin, valproic acid, valproic acid, valproic acid, valproic acid. Otherwise, if we on the other side see, phenytoin also have, carbamazepine also have. So, most important, neural tube defect. It can occur, most important, by the valproates, it can occur by phenytoin, it can occur by carbamazepines. So, already I have told, take extra folic acids and prenatal. Now, there is also one concept. Is the female on multi-drugs or is the female on single drug? Because as the multi-drugs increases, the risk of congenital malformations or all these problems will increase in the fetus. Major malformation, if monotherapy 4.5%, if polytherapy 8.6%. So see, if the polytherapies are going, and also if the sodium valproate is with other polytherapy, other drugs also, that also increases the risk. If probable, valproate as part of polytherapy, possible VPA monotherapy contributes to development of MCS. So valproate is always there. Now question comes, what to do? Higher the dose of valproate, there are different registries, higher the dose of valproate, more are the chances of developmental malformations. So if you see by the risk and the benefit, benefit is patient will not have a seizure if we change the drug. Risk is congenital malformation. So go to the history of the patient. How was the seizure control before the pregnancy? How was the compliance to the drug? What is the dose of the drug? What is the dose of sodium valproate in this? There are still debate going on whether to stop or not. According to the American registry, it says reduce the sodium valproate dose by maximum 600 milligram per day. European study says around 7 to 800 milligram per day. But I will say, like what I have searched all, less than 600 milligram per day dose of sodium valproate can be given. It reduces the risk of congenital malformations. It reduces the risk of neural tube defects in the patient. So these are the different things. But picture अभी बाकी है. Congenital malformation तो हमने खत्म कर दी. Sodium valproate का time निकल गया, आगे चल रहा है. But sodium valproate also causes cognitive impairment. What to do that? For that? Because as the sodium valproate is going throughout the pregnancy, it can lead to cognitive impairment in the child. So we need to slowly, with passage of time, reduce the dose. Ultimately, with span of time, again a debate. Reduce the dose, taper the dose, and ultimately switch over, if possible. Of course, these are the different, with anti-epileptic drugs, what can happen. These are the classes, as I told, class C and class D. So, anti-epileptic drug levels are also very important to monitor during pregnancy. We have for phenytoin, we have for carbamazepine, we have for lamotrigine. So, what to do during labor? Please don't stop the anti-epileptic drug. If she is taking, at least if she is going for a cesarean section, at least by sip of water, give the anti-epileptic. Or switch from tablet to intravenous at that time. Because giving anti-epileptic drug during the labor is very important. Hyperventilation is there if going for the normal delivery. If for cesarean, there is stress, there is again change of hormones. So, and do not leave unattended the patient for at least 24 hours. So I have already told, give injection lorazepam if needed during the labor. After delivery, encourage for breastfeeding. Breastfeeding is important for the mother also. It is important for the child also. So give to the patient. At least baby should be breastfed. Nothing will happen. Please don't consider that mother having epilepsy, बच्चे को दूध ही नहीं देना जी, उसको भी हो जाएगा. अगर दूध नहीं भी दोगे तो फैमिली हिस्ट्री तो है ना, तो फैमिली हिस्ट्री से आगे सीजर हो सकते हैं. ये नहीं है कि ब्रेस्ट फीड से हुआ है. So after delivery, all these things should be done. Thank you so much. I hope I tried to make it clear.
Dr. Pal, it was an excellent deliberation. We all enjoyed so many aspects. I was thinking only of valproate causing neural defects and other things, but you have shown so many issues with drug therapy in women with epilepsy. My question is that if there is so much panga with sodium valproate during pregnancy for defects as well as for cognitive dysfunction, then reduce the dose, change it. why not we should have a consensus that all girls or all ladies who are going to be pregnant, why we put them on valproate? For focal epilepsy, we know that carbamazepine is important, we have to give it. But for generalized seizure, we can avoid using these drugs in this sect of population, and why not start with levetiracetam and lamotrigine for these girls and ladies?
Definitely, sir, you are absolutely right. As I have already showed in the slide, like if the safe drugs, if we think about it or if we talk about it, it's levetiracetam, it is lamotrigine. But what you will do about juvenile myoclonic epilepsy or what you will do about juvenile absent epilepsy? Sodium valproate is good. Otherwise, already neurologists and everybody is getting wise due to, related to this thing. There is a girl, don't put sodium valproate. Other than where definitely sodium valproate is indicated, give over there, otherwise don't give that. As what Dr. Parampreet, we were discussing outside also, he says, I don't put. And that I learned from sir also at that time for reproductive age.
I think this is a very good message for all the audience. And
Yeah, exactly. And actually, in our clinical practice, we don't see much of our young girls or young ladies on sodium valproate, so we don't have that much of problem. Usually, they are nowadays on levetiracetam or levetiracetam. So the only thing is what we do before the start of any treatment as a part of prenatal counseling, send the patient to neurologist back that we are starting with our fertility treatment. So if you want to do something or give fitness to the patient. That's all what we do in our prenatal counseling.
That's why it is the
important message is, yes, folic acid high dose we are giving. But one new thing which I have learned is that the polycystic ovarian syndrome, that can be because of the anti-epileptic drugs, because of the hormonal imbalance. That's quite good and very informative.
Sir, I will say there is no anti-epileptic drug which is safe during pregnancy.
As compared to sodium valproate.
देखना ये है कि आगे कुआं है पीछे खाई है.
As compared to valproate.
Definitely, sir.
Yeah, you want to say that levetiracetam should be given.
Yes.
Okay. Thank you.
And sir, the point of amniocentesis for every patient on anti-epileptic drugs is not correct. So it has to be a structural anomaly scan.
Exactly.
And that's quite good. These days it's very, very good. So amnio is not required actually.
Of course, we should go for further cardiac scans also. Prenatal
that
cardiac
will cover
structure. Yeah.
The level 2
Level 1, level 2, level
yeah.
3, all these.
But amniocentesis, I have not heard about it. We don't get that done in our antenatal patients. Thank you so much.
In detail, Dr. Pull has already said, the best thing to prevent is, and that is not for the gynecologist, it is for people who are dealing with epilepsy patient, is to tell them that you tell us 6 months in advance if you plan to get pregnant. Still, as he said, people will keep coming to us after pregnant and they'll cause a lot of complication. But if there are people, young girls on your follow for a long time, the moment they're planning to get married or even thinking, I've told them before at age of 18 that if you're planning to get married, come that time to us. That we may be able to change the drugs to levetiracetam or lamotrigine wherever possible before that. That is the best way to do about this. And surely levetiracetam is much more safer. It is, the risk is almost slightly higher than no drugs. So levetiracetam and lamotrigine are two drugs currently which are the safest. So in the focal epilepsy there is no problem. We don't have to give valproate. We have oxcarbazepine, carbamazepine, who may not be as safe as levetiracetam but are much safer than valproate. Valproate complication rate can reach up to 10%, which is very high problem. Only in generalized epilepsy, we don't have to use valproate in these girls in any case unless they have already been proven to be resistant to levetiracetam and lamotrigine, which is only 10% chance. If in generalized epilepsy, valproate is, let's say 90% approximately effective, levetiracetam is almost 80 to 85% effective. So what we follow is, as Salil already I was discussing with you, we just start them on these drugs if we have to start. No valproate in this age group, and of course, in due course of time, much before they get married, we will know if they are responsive to valproate or not, to levetiracetam or not. Then we can think of low dose valproate and all those things. Otherwise, majority of them will be able to avoid valproate.
Thanks a lot, sir. May I request the chairperson to honor the speaker of this session, Dr. Slee Loper. Can we have the round of applause, please? एनर्जी थोड़ी कम हो गई है अभी. That's good. And product plants to honor our chairpersons, please. Thanks a lot, sir. So here comes the final session of epilepsy masterclass. Dr. Hanish Pansal speaking on epilepsy surgery. He has in fact a case presentation on that. So may I request Banda and Kavaljeet to escort Dr. Sudhir Sood, Dr. Tushar Arora and Abhijot Parmar onto the dais. Chairpersons, please. I request the chairperson to introduce speaker Dr. Hanish Bansal to the audience, please.
I'm so happy to introduce Dr. Hanish Bansal. He has done his MBBS from DMC, MS General Surgery from SMS Medical College, Jaipur, and MCH from DMC, Ludhiana. He has been a visiting neurosurgeon for epilepsy surgery training at NIMHANS, Bangalore for 1 month under Dr. Malla Bhaskar Rao. Visiting neurosurgeon at King's College, London. Visiting fellow at Westmead Hospital, Sydney. And presently he is working as associate professor at DMC, Department of Neurosurgery. Please.
Yes. Good evening, everyone. First of all, I would like to thank Sandeep sir, Dr. Gagandeep sir, for giving me opportunity to present this case here. So this was a 19 years old male who came to an epilepsy clinic with complaint of seizure disorder since 1 year of age. This patient had first seizure at age of 1 year, and with the mother complained of the patient had uprolling of eyeballs and frothing from the mouth with abnormal body movements. The second episode of similar seizures occurred 2 months later on. The frequency of this seizure was after every 2 months. From last 5 to 6 years, the type of seizures changed, and patient started to look towards the left side with the abnormal movements of the right hand, with the posturing of the left upper limb. The current frequency of the seizure was once in every month, despite on medical treatment. So seizure type 1 was uprolling of eyeballs with frothing from mouth with abnormal body movements, and the seizure type 2 was behavioral arrest with looking towards one side with right hand automatisms, with left hand dystonic posturing. This was a full term normal delivery and no history of delayed milestones. So this was a medical treatment the patient was taking, which was refractory treatment. So there is this is the interictal awake EEG.
Hello.
So this is the interictal awake EEG, which was normal. This shows normal background. No seizure activity was recording in the interictal awake EEG. This was the interictal sleep EEG, which showed a phase reversal in the here, this one, around the F8 in the right anterior temporal region. This was in the again the phase reversal with the sharp waves, and in a PZ montage, these were the sharp waves which are noted in the right anterior temporal region. This is a seizure which was recorded. Patient seems to be lying comfortably in the bed. Movement of with movement of lower limbs, looking towards the left side. Seems to be conversing with the family members. Here, it looks like a someone pause, like some behavioral expressionless something. Now again seems to be conversing with the family members. Now you can see the movement of the right upper limb. Also slight flexion posting of the left upper limb. Now the patient has again regained, is conversing again with the sister. So this is the EEG during the seizure. So here this rhythmic slowing can be recorded from the right anterior temporal region, F8 region. So on EEG and video EEG, we were able to lateralize and localize it to the right anterior temporal region. So in interictal EEG, rare spikes were seen arising from the right anterior temporal region with phase reversal at the F8. And in the ictal EEG, 30 seconds after onset of seizure, rhythmic theta activity was seen from the right anterior temporal region. Two seizures were recorded during awake state with similar semiology. So interictal EEG, seizure semiology, and ictal EEG were suggestive of right mesial temporal lobe epilepsy. An MRI was performed which showed right mesial temporal sclerosis. This is the right side. The ventricle on the right side, temporal horn is prominent. This is the normal looking hippocampus on the left side, and this right hippocampus seems to be atrophied with T2 hyperintensity, which seems to be gliatic change in the hippocampus. Also the loss of indentation, normal appearance of the hippocampal head with loss of normal internal architecture. In plan of EEG and radiological findings, standard anterior temporal lobectomy was planned. So this is a brief about anterior temporal lobectomy in this case. So performing a standard anterior lobectomy consists of resecting the lateral temporal and the mesial temporal structures, either en bloc or separately. Removal of lateral temporal structures, which is the neocortex, allows better visualization of the mesial temporal structures. Anterior temporal lobectomy consists of 3 basic stages. One is the neocortical removal, second is the hippocampectomy, and the third one is the amygdalectomy. Patient is placed in a supine position. The head is rotated towards the opposite side with a pack under the ipsilateral shoulder. The vertex is tilted slightly towards the floor so as to bring up these mesial temporal lobe structures upwards. As this question mark incision is given, extending from the zygoma, then upside pinna and back behind the airline. So this is a view of a right anterior temporal lobe. This is the dura which has been cut circumferentially and reflected downwards towards the muscle. This is the Sylvian fissure of the right side. This superiorly is the frontal and the parietal operculum here, and this is the right temporal lobe. This is the right superior temporal gyrus. This one is the right middle temporal gyrus, which is seen. This is a superior temporal sulcus on the right side. Normally, on the non-dominant side, which is the right temporal right side, around 5.5 to 6 centimeters of neocortical dissection is done from the tip of the temporal lobe. We mark it with the help of a Penfield dissector. We calculate 5.5 or to 6 centimeters. Usually vein of Labbe is present, which is the posterior limit. We try to remain anterior to it. Incision can be either be made on the superior temporal sulcus or in the middle temporal gyrus. So this is starting of a neocortical resection. We have marked the boundaries of a neocortical resection. From the temporal tip, we have gone through the superior temporal sulcus and around, this is right side, so 5.5 to 6 centimeters. On the dominant side, which is usually the left side, around 3.5 to 4 centimeters of the neocortex is removed. So from the tip, we have come back 5 to 5.26 centimeters. Then from T1, superior temporal gyrus, we go down to T2, then to T3, which is the inferior temporal gyrus. Again, diagrammatic representation. This is a Sylvian fissure. This is a superior temporal gyrus. This is a middle temporal gyrus. This is the inferior temporal gyrus. So we have entered through the superior temporal sulcus here. This is a superior temporal gyrus. This is a middle temporal gyrus. This is a superior temporal sulcus. So we have made an entry through the superior temporal sulcus. This is the collateral sulcus. This collateral sulcus usually indents the floor of the temporal horn and forms a collateral eminence. So when we enter the temporal horn, we try to remain lateral to the collateral eminence. If we remain lateral to the collateral eminence, we will, during neocortical dissection, we will do no harm to the midbrain structures. And the other thing is, if we remain medial to the tentorial edge, we will again not harm any midbrain structures. So once the superior temporal incision is made in the superior temporal sulcus, we go to the ventricle. Ventricle is identified by a bluish color of ependyma, and then CSF comes out. The the floor of the lateral part of the floor of the temporal horn is formed by the collateral eminence, which is indentation of the collateral sulcus. So we cut it here, and this piece is removed en bloc. This is the neocortical removal. Again, we can see in this picture, after the resection, it has the inferior limit, we have gone to the collateral sulcus. This is the temporal horn, if you can visualize. We have made the entry into the temporal horn. This whitish structure is the hippocampus here. So hippocampus forms the medial part of the floor of the temporal horn, and here is the collateral sulcus, which is the lateral part of the floor of the temporal horn. So we remain, during neocortical dissection, we remain lateral to the collateral sulcus. So this is the neocortex which we have removed. So this is the removal of the superior temporal gyrus on the right side. After the neocortical removal, we do a subpial dissection of the superior temporal gyrus, separating it from the subpial vessels and the branches of the M4. This is a short video of the neocortical resection here. So we have started from the temporal tip. We have calculated around 5.5 to 6 centimeters here, and we have gone downwards here. So here you can see we have from this posterior incision then is extended downwards inferiorly, and this is the piece of a neocortex which consists of middle temporal, inferior temporal gyrus and the occipitotemporal gyrus lateral to the collateral sulcus. Next is the removal of the hippocampus. The hippocampus has basically three parts: the head of the hippocampus, the body of the hippocampus, and the tail of the hippocampus. The removal of hippocampus involves, first step is opening of the choroidal fissure, then removal of the head of the hippocampus, which is the anterior dissection, medial dissection, and the posterior dissection. Lateral dissection we have already done during neocortical removal. So this is when we have opened the temporal horn. This is the first thing which strikes on the floor of the temporal horn is the hippocampus. This is the choroidal fissure here. So the steps we have mentioned is opening of the choroidal fissure. This lateral part we have already dissected because of the neocortical removal. The first step would be the opening of the choroidal fissure, lifting the head of the hippocampus from the inferior choroidal point. This is the inferior choroidal point just behind the head of the hippocampus, where the anterior choroidal artery enters. This is the head of the hippocampus. This forms the middle part of the tip of the temporal horn. So the first step involves the freeing of the head of the hippocampus, which is the middle anterior dissection. Then we dissect the hippocampus medially, which is the medial disconnection. So this is the opening of the choroidal fissure. This is the choroidal point, inferior choroidal point behind the head of the hippocampus. Then again, all structures situated lateral to the choroidal fissure can be removed easily. Then the anterior and the medial dissection is done. Medial dissection consists of separating mesial temporal structures from the contents of the crural and the ambient cisterns.
You can speed up, Dr. Ani.
Yes, yes. So this is the head of the hippocampus body, and this is the, if we go posteriorly, there will be the tail of the hippocampus, which is the posterior disconnection. The short video to show hippocampectomy. This is the hippocampus. This we are freeing the most middle part of the hippocampus. Then this hippocampus is removed entirely. This is the removal of a hippocampus along with the parahippocampal gyrus, which is done subpially. This is the tail, the posterior part of the hippocampus, which is disconnected last of all. So the last one is the removal of the amygdala, which is a very important part because amygdala merges with the globus pallidus without a clear marker superiorly. So there are some landmarks. We'll go direct to the landmark. This is the inferior choroidal point where the anterior choroidal artery enters, and there's an imaginary line drawn to the ICA bifurcation or the proximal ICA or the proximal MCA. So all the resection should remain inferior and lateral to this line. Superiorly, if we can go and damage the globus pallidus. So whole of the amygdala lies below this line. So this is the picture of a removal of the amygdala medially, and this is the final picture after removal of the neocortex, hippocampus, and the amygdala. This patient did very well and is seizure free but on medication. Thank you.
In 1996, Dr. Hanish, we used to give 25% chances that the patient may still have seizures in MTS.
Right, sir.
So what is the present scenario?
Sir, what we are seeing, around 70 to 80% of patients, yes, they do become seizure free. But what I feel, if the seizure semiology, clinical findings, and everything goes completely with the lateralization and localization, then then MTS surgery definitely benefits the patient. If not cured, the frequency of the seizure definitely decreases.
House is open for questions.
The case Dr. Bansal presented is one of the most typical common epilepsy surgery cases. In fact, 50-60% of epilepsy surgery is this type only. I'm sure you will be having many patients. So, I mean, he discussed more about the technical issues, but the indications, this is one of the best epilepsy surgery procedures. Now, outcomes are nearly 60-70% of them will be completely cured of epilepsy, and now we'll be able to avoid surgery on people who are less likely to improve. Somebody who is having bitemporal focus, somebody who is having discordant focus, all those things can be avoided. Thank you. Congratulations.
Thank you.
So my question is that, is there any disability after resecting such amount of brain tissue?
Usually there is no disability after such surgeries. Yes, there are some complications which are very less. A patient can develop a weakness, permanent neurological deficit, with chances are very less to the tune of 0.5 to 1%. There are some transient visual abnormalities can occur, but the chances are very less, to the tune of 5%. So most of the patient, if you see risk-benefit ratio, the most of the patient benefit from the surgery.
Okay. Thank you.
If there are no other questions, I close this session. Thank you. Thank you.
Thanks a lot, sir. May I request the chairpersons to honor Dr. Bansal. I also request Dr. Goyal to honor our chairpersons for this session. As I say, every good thing comes to an end, but we are not ending here. There will be an extended session in Regent Park with grand gala function there and a lecture from Dr. Naveen Chatkara. Plus there will be fellowship also there. So before that, may I request Dr. Shubhang Agrawal to just come and give the word of thanks.
Good evening. Vote of thanks should be done very quickly. It is my pleasure to propose the vote of thanks today. Foremost, I would like to thank our chief guest, Dr. Raman Sharma, Civil Surgeon Jalandhar, who took out time from a personal family function and still came here. Our distinguished speakers who have come, spared their Sunday and come in for us, Dr. Gagandeep Singh, DMC Ludhiana, Dr. Sayoni Rai Chaudhary from AIMS Delhi, Dr. Jatinder Singh Guraya from DMC Ludhiana, Dr. Prashant Johri from AIMS Delhi, Dr. Parampreet Singh Kharbanda from PGI Chandigarh, Dr. Swapan Gupta from GB Pant, New Delhi, Dr. Malla Bhaskar Rao from Nimhans, Bangalore, Dr. Hardeep Kumar from GMC Jammu, Dr. Salil Uppal from Amritsar, and Dr. Hanish Bansal from DMC Ludhiana. I also thank our special guests, Dr. Paramjit Singh Maan, President IMA Jalandhar, Punjab, Dr. Alok Lalwani, President IMA Jalandhar, Dr. Jasmine Daya, Member PMC, Dr. Ashok Uppal, President Neurosciences Society of Punjab and Member PMC, Dr. Gagandeep Singh again as Vice President Neurosciences Society of Punjab, Dr. R.S. Bal, Secretary IMA Jalandhar. I would also like to thank the forces on ground, all staff and teams of NHS Hospital, reception, IT, maintenance, branding, HR, housekeeping, security, cafe, and our senior administration who have worked enthusiastically and tirelessly to put together this fantastic show for you. Together, we will continue our journey for medical education. NHS will be back with many more shows. Till then, adios. May I request you all to please stand for National Anthem.